Right.
Okay.
Can I start, sir?
I'm starting live.
Yeah, please be on mute. We go live in 20 seconds.
20 seconds live.
We are live.
Lalit sir. Lalit sir.
Audible?
Yeah. Yes, you're audible, sir.
Yeah. I'll just share my screen.
Okay.
So, Cat, is the screen visible?
Yes, sir.
Okay. Good evening, everybody. Greetings to our guest speaker from Brazil, courtesy Natarajan. We all know cataract surgery is the commonest eye surgery all across the globe. After interval injections have recently taken over cataract surgery. And diabetes is one of the commonest metabolic disorders. So this webinar, nicely conceived by our chairman scientific committee of AIOS, shall deliberate upon cataract surgery, that's the commonest, anterior segment surgery in one of the commonest metabolic disorder, that is in a diabetic. So 6 case situations presented by our eminent colleagues will be discussed by eminent faculty. So at the outset, it's my proud privilege to introduce our chairpersons, 2 of the biggest names in Indian ophthalmology, or may I say global ophthalmology, doyens in their fields. Dr. Mahipal Sachdev, President AIOS, Chairman Scientific Committee of IRSI, and Chairman and Managing Director of Center of Sight Group of Eye Hospitals, one of the largest chain of eye hospitals in India. Dr. S. Natarajan, immediate past President of AIOS, Chairman and MD again, Aditya Jyot Eye Hospital. Only Asian to be invited in this BRC meet. BRC meet is, very retina cinema meet, and he's the only Asian to have been invited. Congratulations, Natti, on this. You see, both I have found to be very, very simple human beings, but very, very accomplished in their careers. A lot to learn from Mahipal, a simple man, great entrepreneur, owner of nearly 50 eye hospitals in India. Both are legends in their fields. These 3 Ps, both pioneers, both presidents, and both are Padma Shri holders also. Padma Shri, for our guest, is one of the highest civilian awards instituted by Government of India. Mahipal is pioneer in phaco, flax, refractive surgery, smile. Natti is pioneer in vitreoretinal surgery and including diabetics. He has started a lot of diabetics program, including the one in AIOS, which he very fondly calls it Jyot Se Jyot Jalao. Pioneer of cataract, Mahipal, we have Natti Retina. So we are very blessed to have both of them as chairpersons for this unique webinar, Cataract and Diabetic Eye, very nicely conceived by our chairman, Scientific Committee, Partho Viswas. So over to you, Partho.
I'll just share my screen. So thank you very much, Lalit sir, for being the lead moderator for Cataract in the Diabetic Eye, the case files. And we are here today with the team scientific committee who do so much, all the groundwork, all the hard work done by Amit Porwal, Fairuz, Dr. Jatinder Singh Bhalla, Dr. Krishna Prasad Kurlu, Dr. Parikshit Gopte, Dr. Shomsila Murthy, Dr. Sonu Goel. And we have today as our expert panel, Dr. A. Giridhar, who is the medical director and mentor of Giridhar Eye Institute in Kerala. We have Dr. R. Kim, CMO and Senior Medical Consultant, Retina and Vitreous Services, Aravind Eye Hospital, Madurai. We have with us Dr. Pramod Binde, Director, Sri Bhagwan Mahavir Department of Vitreoretina Services in Chennai, Shankar Netralia. We have with us Professor Namrata Sharma, Secretary of AIOS and Professor of Ophthalmology, Cataract, Cornea and Refractive Services, All India Institute of Medical Sciences, New Delhi. We have with us Dr. Prashant Bavankule, Senior Consultant, Retina, Sarakshi Netralaya, Nagpur. We have with us Dr. Saurav Sinha, Director, BBI Foundation, Kolkata. We have with us Dr. Padmaja Kumari Rani, Network Head, Tele-Ophthalmology Consultant, Retina and Vitreous Services, LVPI, Hyderabad. And we have Professor Rajesh Sinha, the Treasurer of AIOS, Professor of Ophthalmology of Cataract, Cornea and Refractive Services, RP Center, All India Institute of Medical Sciences, New Delhi. And we have the best person ever to moderate this very important webinar, and that is Dr. Lalit Verma, the Vice President, AIOS, Senior Consultant, Center for Sight. With this, I would like to ask our chairpersons to give a welcome note. Dr. Maipal sir and Dr. Natarajan sir, please.
Good evening, everyone, and good morning, Professor George. It's indeed a pleasure to welcome you all to this webinar on diabetes. As you all know, India is the capital of diabetes, as also cataract. So diabetes in relation to cataract surgery, and India does more cataracts than the entire US and Europe put together. Plus China. So therefore, what we are looking at is a predominance of these two diseases in Indian circumstances. And I think until, of course, we really take up the diabetic eye disease with all this seriousness and let people know as to what are the new things that are coming and what are the sight-threatening complications that can happen with diabetes, it is going to become a leading cause of blindness even in India. So I think we have great speakers who are here, and the panelists for discussion are equally eminent. Dr. Lalit, as you all know, has been the chairman of the scientific committee, and Partha, the present chairman of the scientific committee. They are both great academicians. Partha, though being a vitreoretina surgeon, is now predominantly an anterior segment surgeon. So Lalit and Partha, Lalit, as you all know, was at AIMS, and now he's with us at Center for Sight. He's a great vitreoretinal surgeon. So I think both of them will take you along, and the presenters are, I would say, great people who have done a lot of work in retina and are the emerging new heroes within ophthalmology in India in the VR scene. And I think the discussants have been really the pioneers of VR surgery and diabetes management in the Indian circumstances. So I think without much ado, there is a lot of work that is going on in diabetes, and we need to know as to what exactly is happening. I think if you're looking at artificial intelligence, the maximum work is being done on mapping diabetic retinopathy and getting things on track for people to know that they have some treatment to be required. So I think without much ado, we can start on with this case file, which is one of the most interesting webinars that has been crafted and drafted, I would say, by Dr. Partha and his scientific committee. The members of the scientific committee are par excellence, and all of them put together are a great group. So let us see what they have for us in store, and let us all make it a great learning experience. Thank you very much.
Dr. Natarajan, sir.
Thank you, Partha, for the opportunity, and thanks, Maipal and Partha and Lalit for giving an overview of today's program. And as Maipal said, unfortunately, we have the highest number of diabetics in the world. We have about 77 million diabetics, and we have about 6,47,000 villages. And All India Ophthalmological Society is doing a program to make sure we cover all the 6,77 million diabetics in the next 5 years. We have Dr. Kim, Dr. Padmaja, and many others in the DR task force. And with this, I think we also do the maximum number of cataract surgery in the world. And I think we do 6 times more than China. And I'm proud of that. We started the first cataract surgery with that. Now over to you. And thanks again for Lalit and Partha and Maipal for the opportunity.
हाँ बेकर मैम
I'm glad.
नहीं मैम एक वेबिनार में है बोला ना मैम
Somebody has to mute, I think. Yeah. So, George is a great friend. He's part of the many American and South American veterans. And I'm glad he does the maximum Retina World Congress Live, which is one of the most famous with the covering almost 65 countries. Thank you.
Thank you very much,
So,
sir.
Yeah.
Yes, sir.
So the format of this session has been kept relatively simpler so that the audience gains the maximum out of it. You see, we have 6 eminent speakers who will present their cases for 4 minutes or so, which are common clinical scenarios. I think all of us encounter, whether a TSM surgeon or PCSB, encounter these cases every day. And these cases, after presentation for 4 minutes by the speakers, will be discussed by the eminent faculty and the panelists which we have, and they are all great names in their respective fields. But before we go to the 6 case scenarios, it's my proud privilege to invite Dr. Rosha, and all these speakers will be introduced by one member of the scientific committee each, so that everybody gets involved in this entire webinar series. So I will request Dr. KP Kudlu, one of our member scientific committee, and he himself is a great cataract surgeon and owner of Prasad Netralaya and has multiple hospitals now. So I'll request KP to please introduce our keynote speaker, Dr. Rosha from Brazil. Over to you, KP.
Thank you, Lalit sir.
I think it got disconnected, or
Yeah, I think you lost him.
he's showing, but I think the connection is gone, sir.
The connection is gone.
Okay. So we can, Dr. Natarajan, sir, can you, in the
KP?
meantime, invite Dr. Roche?
Okay.
George? Yeah.
I'll. He's come back or no?
KP, are you there?
KP?
Okay, Nati, you can start.
Yeah. So 1 second.
So I think the reason we have Professor George Rosha with us is because before we undertake any cataract surgery, all of us should be familiar that what are the options for diabetic retinopathy management available to us. So that is the reason I think we requested Nati to have one eminent speaker, and we are very fortunate to have George Rosha with us. So he will speak for around 10-15 minutes on management of DR as it stands today. Before we take cataract in mild NPDR, moderate NPDR, severe, such stages, I think Dr. Rosha will describe to all of us, and we'll learn in a great way that how should we approach diabetic retinopathy. So
Okay.
over to Dr. Professor Rosha. Very glad to have you here with us.
Yeah. Lalit,
Yeah.
Dr. Rosha did his medical school in Federal University, Bahia, 1988 to 1993, and residency in the University of Campinas in 1994 to 1997, Retina Fellowship in Doheny Eye Institute, California, 1998 to 1999, and PhD in University of Sao Paulo, 2000-2003, Retina World Congress board member along with me, and Brazilian Retina and Vitreous Society secretary and CBO secretary. And I think more than that, he's a versatile. He's a professor of ophthalmology, and he's a versatile vitreoretinal surgeon. And Krishna Prasad has come. Okay.
Yeah, KP.
KP, carry on.
KP, are you there?
Dr. Krishna Prasad, you have to unmute yourself. We can't hear you. Unmute, please.
So can you hear me, madam? Can you hear me?
Perfect. Call.
Yeah, I'm so sorry. This is the first time I think last 100 webinars I missed the connectivity. I think it can happen to anybody. So
Yeah.
I'm really privileged to introduce such a great man. Of course, he's from Brazil. I think this is the place I yet to see. I think I need to go along with Professor Natarajan to such a wonderful place. He's been the vitreoretina surgeon from Brazil who has been doing a lot of work and also he has done his specialization from California, Los Angeles, and also he has got so many positions. He has been a secretary of Brazilian Society of Ophthalmology. He's a delegate of American Society of Retina Specialists, member of Brazilian Council of Ophthalmology, member of American Academy of Ophthalmology. Also is a member of American Society of Retina Specialists, and also member of Club Vitreoretina Surgeon. So once again I welcome Professor Rocha for this wonderful meet. I think hopefully all our Indian ophthalmologists all around India will be definitely have a lot of points to take from you, sir. Over to you.
Krishna Prasad, can you show the previous slide? I'll just.
Yeah, this is one of the wonderful slide. I think I could be able to see you also.
Director, and thanks to George here. Thank you, George. George, off to you, and you can stop sharing, Krishna.
I can share my slide now.
Yeah,
Yes,
yes.
please.
Please carry on.
Can you see my slides?
Yes.
Okay, let's start. Good evening, everybody. I'm very proud to be here, to be invited. Thank you, the president of All India Ophthalmological Society and the president of the Scientific Committee of All India Ophthalmological Society for this moment, the privilege to talk with the distinguished people. I have no disclosure concerning this talk. I'd like to say some word for my friend, Natarajan, Professor Natarajan. We met something like 5 years ago. We worked along together at the board of RWC. He's a strong voice across the globe, advocating better scientific knowledge, scientific spreading education across all the world, and try to all understand how important is the vision, how important is to take care properly of all patients. Last year, he was here in Brazil. He was the key speaker for our national ophthalmology meeting, and he is doing a very good job. I would like to congratulate this great man. He was a great ambassador of India, and I can tell Natarajan is very welcome in Brazil, and all ophthalmologists too, to come here anytime and cooperate and partner with many things we can do together. Let's start. Diabetics is a pandemic too. That's a huge number of diabetic patients, and India is one of the most popular diabetic in the world. And Brazil has more than 15 million diabetic patients that was not well controlled. The blood sugar and hypertension is something that we should keep controlled, but in the poor population, Brazil is not easy. And we have a very bad case that we should take care and try to prevent the loss of vision. And diabetic is a vascular disease that's gonna damage all the endothelial cell, the tight junctions, and this gonna leak fluid outside the vessel and cause edema. This edema and other complication of diabetes. Nowadays, we have many tools to help patients, like laser, injections, and vitrectomy. And we'd like to start the first thing that's big complication. Around 4% of all diabetic has macular edema that can prevent vision. And in Brazil, we have this PET survey, our Vitreoretina Society, a couple of years ago, and the majority of the doctors start primarily using injections for macular edema. After 3 or 4 injections, they are switched for steroids, mostly with Ozurdex. But what's the best drug to use to manage with the macular edema? The protocol T address these questions, and they shown us that the 3 drugs work well, but if you have 25th or worse vision, the best drug is aflibercept. But if you have 20/40 or better vision, any one of these drugs work properly. And another thing that you have to address is when to switch drugs. And for these questions, we have this post-analysis for Neil Bracelet from US that was published 2 years ago at the archives. And he shown us that it's very hard to predict with only 3 injections who's gonna be in 2 years very good vision or not. They say that with 3 injections, even the person that has less than 5 letters gain can get good vision in 2 years. More than 40% of the group of the persons that has less than 5 letters gain in the first 3 months injections got better. In Brazil, used to do 6 injections and switch mostly for steroids. Another question that we have to address is how do you should treat the proliferative diabetes, with laser or injection? And for this matter, we have the protocol S. The protocol S just published 2 years ago, the 5 years follow-up. And what they shown us with 5 years, doesn't matter if you use Lucentis or laser, the patient's gonna have the same vision after 5 years. And what the visual impairment with macular edema? The ranibizumab group has better vision, less macular edema, but was not so large the difference between the laser and the injection group. And concerning the retina detachment, yes, the group of injections has much less retinal detachment after 5 years than the laser group. But the big question is, what happened with the people that lost to follow-up? And this group from Will's Eyes tried to get all the lost follow-up from the protocol S and answer this question. And what you see, 20% of the patients lost the follow-up. And this 20% that lost follow-up, the person that was treated with laser has better outcome. And the patient that was treated of injection and lost follow-up has the worst vision, more retinal detachment, more neovascularization of the disc, and more neovascularization of the iris. And the other great question about macular edema is when to operate this patient, what you should do. And you used to follow the work, the scientific, and macular edema is only with traction we should address surgery, or persistent, that one that you use injections and that you use steroid and keep very bad edema. And this case, we think some vitrectomy. And why some patients does improve the anatomically, but do not improve vision? Just because we have to look on not only the thickness of the retina. I mean, we need to see more details we call biomarkers. And a couple of years ago, they published a very good biomarker that we call drill. There's organization of the retina inner layer. What does it mean? The patient we can't distinguish the normal layers of the inner retina, even with the improvement of the macular edema, we still have very bad vision gain. Here, a patient of mine that has a very good result after a couple of injections, but very bad improvement in vision gain. Just because we can see in the app, we don't see any retinal layer, and after finish to have the atrophy of the macula. And we have, on top of that, we have not only the drill, but we have another biomarkers that we should look very carefully, like the external lines, like internal limitant line, external limitant line, and ellipsoid line. These two lines is very important. If they are broken, they disappear, probably the patient will not gain a lot of vision, even with the improvement of the macular thickness. And now we'll just go ahead and see what the improvement and the assessment of the patient. The wide angular angiography helped us a lot to see the non-perfusion of the periphery of the retina. And some work are correlating the periphery, the ischemia in periphery, and the macular edema. And this helped us to see better and treat this patient as better as we can. Another tool that is in the burst, but is gonna help us a lot, is the OCT angiography. They can tell us very beginning of the pathology of the vascular in diabetes. They don't show us leakage just because they try to see the vessels by the movement of the cells. But we can see very well all layers of the capillary, the superficial and the deep capillary. This is gonna help us a lot. And this one in my right is something that's really matter in developed countries. It's the handheld retinography. This device can help us screening a lot of patients with all the health professionals that help us and send image for telemedicine, for artificial medicine. And with this device, we can screen a huge number of patients and help a huge number of survivors. Now I'll just talk about surgery. Something that's improved a lot since the beginning, the 70s, is the vitrectomy. We have the better tools, better machines, and the better visual system, like the 3D system. We have drugs, we have many things that improve us a lot, the way to treat these patients. Usually we try to operate as soon as the patient comes to us, because we're gonna have much better results. This challenging case, like we shown in my left, that use bimanual and delaminate with the cutter, the small gauge cutter, is something that it's a lot of effort, but the vision gains is very low. And usually we prefer to use gas for all these patients. And now just to a little picture of the problem of diabetics in Brazil. In Brazil, we have more than 200 million of people, and only 1/4 of these Brazilians can afford with private health insurance. But all Brazilian has the right by the Constitution to the public system that has more around 211 million that use the system. But the system can't afford for everybody with the injections, vitrectomies. And for this, we should prevent bad case. That's gonna be cost less. And this, the Brazilian Council of Ophthalmology, he's the leader to try to produce a lot of material for educate diabetic persons. And in November, the month of the World Diabetic Day, during the whole month, they coordinate a huge screening project. And many doctors all around Brazil, they are volunteers, not only doctors, but also all health professionals. Last year, we gathered more than 2,000 people helping us, and we screening more than 100,000 patients that's saved their lives, diabetic patients. In just a few minutes to end my talk, I would like to say all the health professional, doctor, nurse that are fighting against the COVID, that I have the profound respect. And I have to say, we are together gonna win this fight against this viral. And now I'd like to show you a beautiful picture of my city. The Salvador is from northeast of Brazil, is by the sea, is the fourth city of Brazil. And I hope in the near future, many of you can come here to visit me after this pandemic. Thank you very much to allow me the privilege to be here with you. Thank you all.
Thank you, Dr. Rosha, for this excellent talk. You see, I haven't had a lecture such brief, but conveying everything. In fewest possible slides, very few slides, you covered everything in diabetes, from starting from protocol T to S to surgery, and showed videos also public health problem, screening, and also emphasized about this handheld cameras. So it's open to discussion, and the discussions will be done by Dr. Giridhar and Dr. Natarajan.
Okay. George, for the wonderful talk. And as the talk goes, and most of the people who are viewing today are anti-segment surgeon. So if you have the diabetic macular edema or a traction detachment with the cataract, what's your approach?
I usually try to operate at the same time, because with cataract, the cataract prevent us to see well the back of the eye. And then we can't do vitrectomy well, we can't see of the no perfusion area to be treated. And it's very important, all this patient that has combined disease, cataract and diabetic retinopathy, they should have to go first to cataract, and or simultaneously to have the cataract and injections of vitrectomy as they need.
You see, this will be covered by one of the speakers also. Giri, any comment?
I wanted to, ask him a few questions. Very nice talk, Professor. And thank you, Nati, for having invited him. I had, there is a lot of similarities between India and Brazil. We are both developing countries. And I was interested in knowing what is the practice pattern in Brazil. Do you use bevacizumab? Bevacizumab, that is Avastin. Do you use Avastin?
Yes, we use a lot of Avastin here, mostly in the
Avastin in Brazil for the treatment of diabetic macular edema. Number two is, I was also interested to know whether a pan-retinal photocoagulation is the standard of care for PDR or other doctors who are using anti-VEGF in the management of primary management of proliferative diabetic retinopathy.
Yes, in Brazil, for the proliferative diabetic retinopathy, we use laser photocoagulation. We have no money to inject in this patient, and it's very hard to follow these patients. The most of these people were not well educated and understand the high necessity to see doctors very frequently. And in Brazil, the system do not afford to injection for proliferative diabetes. And macular edema in the public system use mostly Avastin. But in the private health system, they can afford aflibercept or Lucentis.
Do you have compounding facilities for bevacizumab, Avastin in the Brazil?
Yeah. We have compounding pharmacies that help you to split the dose and help us to do this. And then we use many Avastin here, but photocoagulation is the primary approach for all Brazilians nowadays. We don't forget the laser because it's very important. As I show you with the protocol C, 5 years. Doesn't matter if you're injecting or do laser. After 5 years, the vision gonna be quite the same. But does matter if the patients lost the follow-up. When you lost the follow-up, the people will come you with very bad neovascularization, iris neovascularization, retina neovascularization, and all kind of bad things that can happen in diabetics.
Yeah, okay. Even in India, actually, PRP, PRP is the primary form of treatment. I don't think that, in India, anyone is giving anti-VEGF as a primary mode of treatment. And the last comment I wanted to make, Lalit, is that I think we can work together.
Yes.
Brazil and India can work together. Nati?
Yes,
for
definitely.
sure. I think it's going to be very good to partner with India. We are very close societies in the same way of development. And the large number of people, we're not like you that have more than 1 billion, but we have 200 millions and growing. And we have many problems, social problems, health problems. And I do believe that India has a lot to help us, and Brazil may help you too.
Thank you, Giri, for bringing in this laser, because I was, once I was hearing talk of Dr. Rosha, I thought he is deliberately, underplaying laser, because none of these slides showed laser actually. And I'm happy that Giri brought out this point. As in Brazil, so in India also. You see, PDR, still standard of care is laser. A very good laser done, and we have a follow-up for more than decades, 3 decades, patient doing very well. You see, affordability is an issue here also. And only indication of using anti-VEGF drugs in PDR would be when you have maximally done the laser and still patient has some ooze, or the front is in a very sensitive area despite laser persisting in the posterior pole. Then only we do. Thank Giri for bringing this out very, very nicely. And thank you, George, for briefly summarizing the entire DR management for the benefit of the Indian audience. I think we move on. And
we were requested, Lalit, we have requested George to be there so that he can add after each presentation.
We will request Dr. Rosha, in case time permits, you please be around, so that we would require your comments in the subsequent presentations also. I'm sure they will be very interesting, because case presentations are there, and they will be, very, very, day-to-day issues will be brought out. And the first presentation is by Dr. Avendra Gupta. He will be presenting a situation of cataract with NPDR and no diabetic macular edema. And I will request Dr. Feroz, young dynamic member of scientific committee of AIOS, to give a brief intro about Dr. Gupta.
Thank you, Dr. Lalit. I'm going to share my screen.
Yeah, please carry on. Yeah, clearly
Hope
visible.
it's visible and I'm audible.
Yes, carry on.
Hi. Good evening, everyone. On behalf of the AIOS Scientific Committee, it is a pleasure to introduce our next speaker, Dr. Avneendra Gupta. Sir, it's a privilege to have you with us today as well. He's the director of Nayan Jyoti Eye and Laser Center at Faridabad, Haryana, India. Being an alumni of Banaras Hindu University, he pursued his career for fellowship in vitreoretina at Aravind Eye Hospital, Madurai. And following that, he also took up as in charge and chief of the Department of Vitreoretina in Aravind Eye Hospital, Tirunelveli. During his illustrious career, he has trained numerous ophthalmologists and delivered various lectures in the regional level, national level, and international level on various subjects surgically on vitreoretinal diseases. And he also is a recipient of the Best Video Award at URetina London. He's also part as a national faculty in various postgraduate teaching program, and he has been a very active teacher and a great academician. It is a pleasure for the entire team of AIOS Scientific Committee to have Dr. Avneendra Gupta delivering the next talk of the day. Over to you, Dr. Avneendra Gupta. Welcome. Thank you so much.
Thank you, Feroz. Avneendra, you can upload your talk, Feroz.
Thank you, Dr. Feroz, for my introduction. So can you see my slides?
Yeah, nicely. Please carry on.
Yes.
Start from number 1.
Thank you and good evening to everyone. Thank you, Dr. Partha, for giving me this opportunity. What I'm going to talk is cataract with mild non-proliferative diabetic retinopathy with no clinically significant macular edema. I like to stress that cataract comes first because of the variation in the blood sugar levels. Cataract comes first and then comes the retinopathy. So most of the patients with cataract will have non-proliferative diabetic retinopathy. Here is a case, a 55-year-old male came to us with complaint of decreased vision in left eye. Patient was a known diabetic for last 5 years. Vision in the right eye was 6.6 and that in the left eye was 6.12. IOP was 13 and 16 millimeter of mercury. Anterior segment showed nuclear sclerosis with posterior subcapsular cataract. You can see fundus, it's near normal fundus with few microaneurysms seen in the periphery. There is no clinically significant macular edema. So the obvious choice in this patient is you go ahead with the cataract surgery, and the preferred mode to do cataract surgery is MICS, that is phacoemulsification with IOL implantation. The important thing here is you should make a large rhexis, put a large optic IOL, because if you make a small rhexis, then you are not able to visualize the posterior segment due to phimosis of the rhexis. Patient recovered with 6.6 vision. After 3 weeks, patient started complaining of blur in vision. Now you say that you have done a very good surgery, patient has recovered with 6.6 vision. Why the patient has complaining of deteriorating vision? Vision, when he came for examination, his vision has deteriorated to 6.12 and he says, I'm not able to see clearly. We did a dilated fundus examination of this patient. You can see hyperpigmented cyst on the posterior pole, not much of macular edema. If you see this hyperpigmented cyst, then the clinical diagnosis comes to be a post-operative cystoid macular edema. The incidence of post-operative cystoid macular edema in a normal cataract surgery is 2%, but in diabetic, it's 6 to 8%. So if you are operating a diabetic patient, then keep in mind if patient comes with a decreased vision after 3 to 4 weeks, then look for cystoid macular edema. So we did a fluorescein angiography for this patient. You can see a flower petaloid pattern. And OCT is the investigation of the choice where you see cystic changes in the macula. Now I go for a discussion. I'll ask my panelists, what is the line of management? What is the role of prophylactic NSAID? Posterior subtenon injection is more effective, or should we go for intravitreal steroids like IVT or DEX implant? Can I ask Dr. Saurabh?
AG, the discussants for these are Dr. Saurav and Dr. Rajesh. Saurav, can you please comment on this? No diabetic macular edema prior to surgery, cataract surgery. Patient recovered good vision. Now he has developed a cystoid macular edema, which can happen in any cataract surgery, but incidence in diabetics is fourfold. We should all remember. A lot of people talk about step ladder pattern and pre-op use of say bromphenic or NSAID drops and continue. So his question is about line of management now, 6 to 612.
I would definitely, since it's only 3 weeks post-op, I would definitely go ahead with only Nepefenac only. Buy some time from the patient, explain to him. Definitely no talk about intravitreal steroids or intravitreal, any intravitreal injection as of this point. Tell the patient, give him more time, especially I'm talking from the cataract surgeon point of view. The cataract surgeon needs to explain to the patient, this is nothing to the cataract surgery itself, and that this is going to take a long time to go away, and there's no hurry in jumping to injections to wait for at least 2 to 3 months. It will recover probably before that, but telling the patient that you have to wait for at least 3 months to come back to normal, I think is more important. And seeing only topical Nepefenac, I think, should work in these patients.
So, Saurabh, for how long do you want to continue?
At least 6 weeks, at least.
So 6 weeks, you don't want to see him?
No, I will keep seeing him every 2 weeks.
Okay. Dr. Rosha, any comment on this?
If the patient's prevalence of the surgery has macular edema, and I do use intravitreal injection to treat before, but if I don't know anything and I just go to surgery, and after the surgery we has this edema, I do start with drops, non-steroid and steroid drops for 1 month, and if it doesn't work, I'm thinking to go for injections, anti-VEGF. But at first, I start with drops too.
Yeah, I agreed, because this patient pre-operatively, he did not have any diabetic changes. OCT was normal, but this cystoid macular edema developed post-operatively, that too after 3 weeks. So I think all of us agree that because spontaneous resolution of cystoid macular edema is a rule in more than 90% of patients.
Can I add something, Lalit?
Yes, Giri, I'm coming to you.
Yeah.
Yeah, so I think NSAIDs have to be started in the, but visual criteria, you see, normally what I would do is, if the vision is say 612 or slightly less, I am a very early institution of posterior subtenon injection. You see, because if the vision is slightly more, he has put it on the edge, 612. So I will wait for some time. If it is, if it was 618 or 624, I would have straight away given PST. But if it is 6/12 or 6/9, I agree with Saurav that, couple of weeks of NSAIDs should. Yes, Giri, now you can comment.
I mean,
yes.
No, I thought I'd just add 1 or 2 points. One is, Saurav, the thing is that as far as a cataract patient is concerned, he will be very apprehensive, because this is a surgical procedure where, he is expecting good results immediately after surgery, and any complications. So if we tell him 3 months and all, then, it really puts him off. So I think we have to, patient counseling is very important, and it should be done in a very, methodical way over a period of time, rather than, just tell him that you have this problem, don't worry, 3 months later. So number one. Number two is that I agree with Lalit. And I think since he has had moderate NPDR, I think the ETDRS map has to be seen whether he had any center sparing thickness, increase in thickness, because patients who have a center sparing increase in thickness, the foveal thickness may be normal, But so some of them, immediately after cataract surgery, it progresses to a center involving DME. So in case after 3 to 4 weeks of treatment with Nepafenac, there is no improvement at all, I may do a fluorescein angiography in this situation just to see whether there is, to confirm whether it is a cystoid edema or whether it's a pseudophakic cystoid edema or whether there is an element of diabetic macular edema in this situation.
Agreed. You see, all of us agree that couple of weeks of NSA drops, if no improvement, have low threshold for injection. Yes, Saurabh, you have a comment or?
Just one comment. I agree for the cataract surgeons, no angiography initially, stick to OCT, angiography only at a later date, because Dr. Avindra showed the angiography nicely for far better, but I don't think it's advocated 3 weeks post-op category, because again, that would put the patient off very much, having further investigation. So I agree with Dr. The way he did the case, but no FA initially, only at a later date.
Agreed. I was also coming to that FA should not have been, the main investigation initially. If it is about only documentation and other thing, otherwise FA generally is not required for the first diagnosis of CME. Yes.
I agree to it because first we go for a non-invasive investigation rather than go for invasive investigation. But to complete my case, I have put this fluorescein angiography.
So let's ask Dr. Avneet Gupta, what did he do ultimately? Yes.
Sir,
go to your slides.
Sir, can I go to my slide presentation?
Yeah. Go to your slides. So what did you do? After, improving 6.6, then coming to 6.12 again. So I agree, Giri, that patient's apprehension, after having improved. So AG, what did you do? Come to directly to the point. What did you do?
Sir, if we see the management is stepwise management. First thing, we add NSAID to the line of treatment with steroids, and if it does not resolve, then I start IOPAR, SR or Diamox once a day. And
no, can we have what did you do in this case, because it's a case file?
Yeah, I waited for 15. I waited for I added NSAID and added Diamox for 2 weeks, and still the patient vision didn't improve. So I gave a posterior subtenon injection, and after 3 weeks or 2 to 3 weeks, the edema resolved, and patient again got back 6.6 vision.
Okay, so I wanted comments from the panelists with regard to Diamox or acetazolamide being given in dosage of 500 milligram.
Once a day, sir. Once a day.
Yeah. So can we have comments from, say, Dr. Pramod Bhande or Dr. Giri about the use of Diamox?
Pramod?
Diamox, I am really not very sure about whether how really effective it is. So yes, NSAID probably yes, I would give. But just coming back a little bit also, Dr. Giridhar says, because we know these eyes are prone to have a edema, they are prone to have worsening of retinopathy, any inflammation in the eye and intervention in the eye. So counseling is very, very important to start with. So, but Diamox, I am not very keen. Probably yes, NSAID I continue, but I just have a word again, and probably cataract people know more than me. Like 3 months or 4 months NSAID, probably particularly Nepafenac have his own issues. So I would choose maybe Ketorolac or other sort of things. If you're particularly looking for a long-term effect, it does help. And even if there are reports, it sometimes takes 6 to 12 months for edema to completely subside, which is, I'm talking about post-cataract surgery edema, not even DME, I'm not talking about here. So we have to be aware of that. So it's a long-term treatment. Keep on following, keep on treating. Don't expect dramatic results in 2-3 weeks.
Right, sir, I would like to make a comment, if you allow me, from a cataract point of view. Lalit sir, now since we all do cataract surgery and we get this type of patients, so my 2 questions: would we give prophylactic NSAID like Nepafenac post-operatively?
I am coming to that. First, let the treatment finish. We'll come to prophylaxis.
Okay, and what about the size of the rexis? Avindra mentioned that you should have a large rexis. We all cataract surgeons, we make a 5.5 to 6 millimeter rexis. that is a large rexis itself. So what do you mean by large rexis in a diabetic patient?
Yes, Amit, this question will
this?
continue for, in surgery when the patient comes for surgery also, and lasers also. Padmaja, about Diamox, are you a user of Diamox in such situations or not?
No. Diamox, I think we have to stick with the NSAID use only.
Yeah.
Like a stepwise ladder pattern, and also seeing in the visual acuity also taking into account in a stepwise algorithm, and also systemic control as well.
Yeah. That Rosha, what is your choice of NSAID? Is it Bromfenac or Nepafenac?
I prefer Nepafenac. I have good results with Nepafenac, but both work well if you persist. After 1 month, if you have some improvement, I think it's good to persist for 3 months. But if after 1 month, 1 month and a half, have nothing, sometimes I think to switch for different drug. I mean, to inject, thinking about the macular edema caused by the diabetic. But the Diamox, I don't use. I don't think the physiopathology is going to help a lot in this kind of macular edema.
Okay, we'll move on. We will move on to the second case. And before we move on, AG, any comment about Amit Porwal's query? I think he mentioned that we have to have a large rexis. You see, all posterior segment surgeons, suppose the case requires a laser or suppose the case requires surgery, a large rexis is always beneficial. Any comment, AG, you can say?
Yes, sir. I'll suggest that the rexis should be somewhere around 5.5 millimeter to 6 millimeter. Because if you have an phimosis of the rexis, what I showed in this case, most likely if you have to do any kind of posterior segment intervention like laser or surgery, then we usually cut this phimosed capsule with YAG laser. That tends to enlarge the capsular rexis and our viewing becomes better for the posterior segment.
Okay, I think we move on to from mild NPDR now to a patient who has moderate NPDR along with CSME. And we have with us Dr. Gopi, and I will request Dr. Somshila, if she is there, to please give a brief introduction of Dr. Santosh Gopi.
Yes, Dr. Verma, thank you very much. Good evening once again, everyone. And it's my distinct pleasure to introduce Dr. Santosh Gopi Krishna. Dr. Gopi Krishna finished his basic medical education from Kasturba Medical College in Mangalore in 2000, followed by doing his post-graduation from Narayan Nethralaya. After that, he went on to do Rajiv Gandhi University Health Sciences recognized vitreoretinal fellowship from the same institute. And currently he serves as faculty in the vitreoretina department from 2011 in the same place in Narayan Nethralaya. It's wonderful that he believes medicine is a combination of clinical skills and not to forget the human touch. And he believes that's what he brings to his practice and patient care. And I'm pretty sure that that's what he does. His areas of research interest as well as clinical interest include diabetic retinopathy, age-related macular degeneration, and surgical retina. So I hand over to Dr. Santosh Gopi Krishna and look forward to listening to his excellent presentation.
Thank you, ma'am. Thank you for the introduction.
Santosh, you can upload.
Yes, sir. You can see my screen, sir?
Yeah. Please carry on.
Yeah. Good evening, all. At the outset, I'd like to thank AIOS and Dr. Partha for this opportunity. I'll be talking on cataract with presenting with moderate NPDR and CSME. So this is about a 59-year-old gentleman who presented with the complaints of blurring of vision in both eyes for 2 months. Coming to his systemic issues, he was a type 2 diabetic patient with normotensive on treatment with insulin for 7 years, but he had fluctuating blood sugar levels of HbA1c of 7.5 with normal lipids and hemoglobin. He did have a diabetic foot ulcer which was healing. The vision in right eye was 618 and left eye was 612 with NS1 to 2 cataract in both the eyes. So since the cataract was not very significant, the other major issue was the moderate NPDR with CSME. I don't have a fundus photo of this patient, but Since he presented with fluctuating blood sugars and healing foot ulcer, to rule out PDR, had advised FFA, which showed delayed arm retina time of 24 seconds and NPDR changes in both eyes with CNPs and a distorted FAZ. OCT showed a mixed macular edema with cystoid changes as well as subretinal fluids and intraretinal hard exudates in both eyes, left eye more than the right eye. So this was a presentation, and post one injection of ranibizumab 1 month later, there was a good resolution of macular edema with intraretinal hard exudates still present, with a good improvement of vision up to 6-9 parts in both eyes. The patient was again seen after one more ranibizumab. After 2 months, the edema in the right eye was much better with some amount of hard exudates, wherein in the left eye, there was a recurrence of macular edema with CME as well as SRF. So after that, the patient was lost for follow-up for 5 months, wherein the macular edema had recurred, mostly CME with spongy thickening and intraretinal hard exudates in the right eye. Whereas in the left eye, there was subretinal fluid also that had come up. So since there was recurrent macular edema, I went ahead with Ozurdex and a modified grid in both eyes. 3 months later, we could see the foveal hard exudates, the hard exudates which were there, they started migrating towards the fovea, but the vision maintained at 6-12 parts, whereas in the left eye, the cystoid macular edema persisted with the SRF coming down, whereas the hard exudates also started kind of accumulating. So there were multiple injections, Ozurdex and again modified grid, which was done over the next 1 year. But the patient was lost for follow-up for 4 months after the latest both eye Ozurdex, and BCVA dropped with advancing cataract. So when we saw him 4 months post both eye Ozurdex, we saw that the vision in the right eye dropped to 624 and in the left eye dropped to 660, with cataract increasing to NS3 with PSC in the left eye. So in the right eye, again, there was a cystoid edema, left eye, again, cystoid edema with lots of HRDs, the hyperreflective dots. So I advised both eyes cataract surgery 2 weeks apart with concurrent IVT. IVT was given at the same time of cataract surgery. So this is a fundus photo post 1 month cataract surgery with IVT. Vision in the right eye improved to 6-9 and 6-12 in the left eye. We can see the Ozurdex implants, which is degrading. So edema had significantly reduced in both eyes, but there are some amount of intraretinal hard exudates and HRDs. 3 months post cataract surgery, maybe the Ozurdex got absorbed. Then there was a bilateral recurrent macular edema which happened, and the right eye PDR, the diabetic retinopathy progressed to PDR, which was confirmed on FA, and there was dropped vision again in both eyes. So this time there was SRF that had formed in both eyes, with again HRDs and SRF even over here. So 1 month post both eyes Ozurdex, the response was not the same. I mean, even after right eye PRP. So this time the resolution of edema took time. 1 month post Ozurdex, SRF came down a little bit, but HRDs persisted, and we can see the changes in the architecture of the macular layers also. You can see that there is drill-like changes and changes in the outer retina as well. So this is the latest follow-up in August 2020. This is the review of 5 months post Ozurdex, and vision in the right eye was maintained at 612 and 636 in the left eye. SRF again increased in the right eye and the cystoid edema, and this time ERM started forming. So coming to systemic status, his diabetes was still uncontrolled with the HbA1c of 8.8, and this time he developed hypertension in the meanwhile, and diabetic nephropathy, creatinine was 2.8, and again diabetic foot ulcer, which was there for 6 weeks, hemoglobin was 12. So this was a diagnosis, and macular edema treatment still continues. I had advised FA and intravitreal injections after physician clearance in view of nephropathy as well as the foot ulcer. So to summarize, we do kind of see many macular edemas, especially CSMEs, simple spongy thickening and all, which are amenable for focal laser, modified grid, or centrally involving DME where a few injections are required. But this case especially highlights the advancing diabetic retinopathy with recurring bilateral diabetic macular persisting even after cataract surgery. So a brief history roundup, wherein it's a 59-year-old gentleman with type 2 diabetes, started as a moderate NPDA with CSME and cataract. Cataract and diabetic retinopathy advanced with time and treatment when we advised both eyes cataract surgery as well as a concurrent IVT. Advanced systemic conditions also advanced over a period of 3 years. And there was corresponding retinal layer damage to the inner and outer layers. So we need to kind of watch out for these changes for a period of time, which can lead to poor visual outcomes in recurrent macular edema. Thank you.
Thank you,
for letting me
Santosh, for a nicely worked up patient and long follow-up and follow-up with documentation. That is what is very impressive about your case, that you have follow-up with photographs of every follow-up. I think this case just highlights, you see, patient was lost to follow-up at least multiple times, 5 months and again
Yes.
a lot of time. Because what Giri had initially said, and a lot of people also agreed, that the importance of metabolic control and counseling, the need to tell for regular follow-up is very, very significant. Because if patient loses follow-up, then rebound edema, then ultimately, drill and ERM, everything starts. Metabolic control also is good. So I'll request Dr. Kim and Dr. Pramod Dhande to take the lead in discussing this case.
Thank you, Dr.
Yeah, Kim.
Yeah, thank you, Dr. Lalit. And that's a very good presentation, actually, for Dr. Santosh, with the well-documented images. I should congratulate him on that. Patient showed moderate NPDR when he presented, but subsequently he improved, and then again he was going down. It's very typical of these patients, especially when we see over a long period of time, how these patients, when they get to, when they're lost to follow-up, you tend to see these changes happening more frequently. One important thing, even in the second and third visit, I was just looking at the OCT when he was talking about the hyperreflective spots. It seemed to show even in the third visit, there was a ring of like this pearl necklace sign. That kind of indicates that these patients are going to worsen over a period of time, in spite of repeated follow-ups, and more so that these patients should be seen more frequently than probably every month or something. But I think over a period of time, you did the course. I would have done exactly what Dr. Santosh had done in the periods that the patient visited, especially switching over to Ozurdex in those cases.
Pramod?
Yeah, I totally agree with Dr. Kim. Exactly, probably I would have done same course. But when I look at it at the 3-month follow-up post Ozurdex, and as we know, like though 4 months, 5 months, 6 months, but I would have just more or less the moment start bouncing back. I think after 3 months, I would have still, that time itself, I would have suggested go ahead with another Ozurdex probably in that in both eyes. So, but I think that's an inherent issue we have. Follow-up issues are there. It's beyond anybody's control, and whatever he was doing, I think is the right way, right approach what he had.
Rosha, what is your threshold for shifting to steroid after injection? 3 injections, 6 injections, or what is your protocol?
Very good case, very good presentation. This kind of patients is like we facing here in Brazil. That's, well, the patient has very bad control of diabetic and hypertension, and the follow-up is not easy because the patient not keeping coming every month. And I think the doctors did a very good job with the case. And if you see, the patients respond well at first with the injections, but because they lost follow-up, they come worse and worse and have to inject Ozurdex. Here in Brazil, my practice, based on the trials, I keep doing 6 injections. If the patients improve, I keep inject for a long time, following the protocol I, like 8 to 9 injections in the first year, and second year 3 or 4 injects, but keep inject for 4, 5 years, and this helped me a lot. But only with this, after 6 injections, if it has no response, I think to switch for Ozurdex and try to re-inject Ozurdex every 3 months, because after that, usually the Ozurdex does not work well. And then sometimes I put vitrectomy too.
I agree. I'm sure Santosh must have offered this, but somehow patient did not come for follow-up. The issue here, like you rightly said, is of metabolic control, poor control, and for follow-up not so good. Yes, Giri, you
So
want to
I would
take
like to add here.
I thought I'll just add one more point. That is, a patient has got nephropathy. I mean, creatinine is quite high. And that is, again, another very important risk factor for progression of diabetic retinopathy. And whenever we operate on these sort of patients, especially cataract surgery, I think we have to be very careful because basically the chance of worsening is much faster, much quicker, and more rapid. So that's another important point. I like that point. He has looked into the hemoglobin. That's very important.
Yes.
Because many of these patients have associated anemia.
Yeah.
And that again is another very important factor for rapid worsening of diabetic retinopathy. Therefore, from a cataract surgeon point of view, when you're operating on some of these patients, I think all these investigations you must do pre-operatively because it gives you a good idea as regards to what are all the metabolic anomalies that the patient has. And, you know, the retinopathy may not look that aggressive before the cataract, but with all these metabolic parameters going haywire pre-operatively itself, post-operatively, there is a rapid worsening.
Any other comment? Yes,
one point just wanted. Sorry, to add one more point here.
Yeah,
when you look at this, easy to say for us that patient is not following properly, but probably we need to understand patient may be going in and out of the hospital with all his systemic problem, get admitted there, and that's why losing follow-up here.
Yeah.
And if you have a obvious deranged parameter as far as nephropathy is concerned, rather I would wait for those parameters to come down. I won't mind waiting for a month or two before actively changing my treatment plan. Because if those parameters, nephropathy comes under control, I think edema, macular edema sometimes just settles down on its own as well.
You see, the message for the anterior segment surgeons is that such patients require a very stringent follow-up and no cataract surgery in moderate NPDR or should be done without OCT. They have to have the control and maximal drying effect on the retina before cataract surgery is undertaken. Otherwise, you see all this, visual improvement and negative effect of cataract surgery starts coming up. Now the problem is that patients started with 6.6 and 6.12, 6.18 and 6.12. Now it's back to 6.12, 6.36, and ERM also is forming. So now issue is slightly more complicated issue now.
Dr. Lalit, it is all the more it says that these patients, we need to look at their metabolic status more often than we tend to do it. That's something, because this case, initially when he presented, had a good, he didn't have any nephropathy or anything. But somewhere along the line, he has been...
See, all of us keep saying about this, but believe me, whatever you say to the patient, whatever you stress, ultimately the practical real-world scenario is a lot of these patients, unless and until, very few of them adhere, by and large, the control remains fluctuating up and down, and kidney issues and other issues start cropping. So we'll take one last comment from Dr. Avneet Gupta and move on to the third presentation, because Partho is not very happy with a lot of extensive discussion because he wants to move on. Yes, Avneet, final comment before I move on to the third case.
So one thing, giving steroids every 3 months, we have two glaucoma surgeons here, Dr. Amit and Dr. Jatinder.
Yeah.
So if you start giving steroids, Ozurdex or IVTA, the incidence of glaucoma becomes pretty high. What Geneva trial says Dex implant should be given after 6 months. Even the company is recommending after 6 months. So what's your take?
It does not work for 6 months. I agree. From one point, I agree with you that glaucoma, optic nerve analysis and pressures we have to take into consideration. But 6 months Ozurdex does not work. It works for around 3 months or so. It does not work. So repeat injection required. But optic nerve health as well as the glaucoma consultations are required. In between that, I 100% agree with you. I think we'll move on, if all of you permit, to the third case. So mild NPDR covered, moderate NPDR covered. Now we move on to PDR now. This PDR patient does not have vitreous hemorrhage. And we have with us Dr. Shalabh Sinha, who will be, presenting this case. Shalabh will be introduced by Dr. Bhalla. Dr. Bhalla, are you there? Hello?
Bhalla.
Yeah, okay.
Yeah. Hello. Am I audible, sir?
Yeah, carry on.
Yeah. So it's my pleasure to invite and introduce Dr. Shalabh Sinha on behalf of All India Ophthalmological Society Scientific Committee. Dr. Shalabh Sinha is a senior consultant Vitreoretina, Raj Retina and Eye Care Center, Patna. Shalabh Sinha is a prominent ophthalmologist of India, providing dedicated healthcare services and treating ophthalmology patients since last 14 years. He has set up an exclusive Vitreoretina center in Patna, which was first of its kind in Bihar and Jharkhand. Dr. Sinha is first among the vitreoretinal surgeons in eastern part of India to start minimally invasive vitreoretinal surgery with 25 and 23 gauge vitrectomy at his center. His indomitable dedication and research inclined approach in the field of ophthalmology has helped him to bring DORC 20 and 23 gauge valve cannula system to his armamentarium. Over to you, Dr. Shalabh Sinha, all yours.
Thank you, Dr. Bhalla.
Yes, Shalabh, you can start. Bhalla, you can stop sharing.
Well, thank you, Dr. Partha Biswas, for giving me this opportunity. Okay.
Yes, Shalabh, we can see. You can carry on.
Am I audible to everyone?
Yeah. Please carry on.
So the problems with cataract, as I see it from a cataract and retinopathy perspective, is that you have a media opacity, you will not get a good FA or a good quality OCT image. It's difficult to do laser. And in many of these patients, if you do just cataract surgery, the patient actually, if you do just retinal treatment, the patient perceives no improvement in his vision. And if the patient does not return for laser or for anti-VEGFs in time, this patient is most likely going to progress to a progression from his PDR to a TRD or a vitreous hemorrhage. So a combined surgery needs to be done for these patients. Either you do a phaco IOL and an anti-VEGF, or as I have done for this patient, phaco IOL and a vitrectomy and endo laser. The issues with the combined surgery is that if it's a hard cataract, during the surgery, you will have more of corneal edema. And in combined surgeries, we do get more inflammation. And if you are having, if you're going to use a single use anti-VEGF, then the cost for the patient is going to go up. So this is the patient that I saw in October in 2015. At presentation, he had this macular traction, and you can see the fibrovascular proliferation in the fundus photograph here in the right eye. In the left eye also, he had this ring-like structure, the fibrovascular proliferation, and the OCT showed the thin ERM and the spongy. So the right eye underwent phaco along with the vitrectomy and endo laser. The vision did not improve much as he had these large cystoid spaces, but you can see that there is no traction. 1 month later, 2 weeks later, the edema or the cyst, they have coalesced, but it's less than before. But the other eye, I started doing a pan-retinal photocoagulation for this patient. And this eye also had these large cystoid spaces after 3 sittings of pan-retinal photocoagulation. And at this stage, I gave him an anti-VEGF. You can see some amount of the cystic space has come down, but the thin ERM still persists. This is the left eye of the patient. Then the patient was lost to follow-up as he did not perceive a good visual gain, but then came back. And if you remember the photograph I showed you of this patient, the right eye, the cystic cavity here has come down. The left eye also seems to have settled down a bit. You can see the laser marks here. And the ERM is still there. The vision, however, from counting finger went up to 660 in both the eyes. Add-on PRP was done for the left eye, as I felt that he needs to undergo vitrectomy also in this eye. And the right eye, I didn't do anything. The vision stayed as 660, but he had these large cystic spaces still persisting. And the left eye, you can see that the media has started to become hazy because of the cataract now progressing. Again, the patient was lost to follow up, but when he came back, the vision had improved to 624 in the right eye. You can see the clear media because the cataract has been removed, but the left eye, the cataract is progressing, and the poor quality of the image is due to the cataract. So I think, as Dr. Rocha also mentioned, that, and we have seen in the past also, these patients, if they don't come back, at least my patient did not progress as far as the retinopathy is concerned. He is more or less stable because the PRP was done at the probable opportune time. So we should not delay in doing the PRP. So this is my case, sir. Thank you.
Thank you, Shalabh. Again, good documentation. The discussant for these are Dr. Padmaja and Dr. Pramod. So Padmaja, would you like to initiate some discussion based on whatever Shalabh has presented? Yeah, Padmaja, you can unmute.
One factor I felt in the case presentation was the vision, and actually the extent of macular edema was not actually correlating. So whether was it the cataract grade was significant enough to start with was something I was thinking about that. And second factor is definitely in terms of progression of the visual recovery after the cataract surgery in this edema. I think it is we need to see what is the best corrected refraction, and as well as what is the near vision quality also, how it has improved significantly, because I didn't see any biomarker, any OCT biomarkers that can be explained, which can responsible for poor vision in this. The ellipsoid zone, the photoreceptor, everything layer was intact, and the traction was also not very obvious.
So I think Shalabh must have presented BCVA only, and the degree of OCT and vision may not always correlate. That also is there. But I think right eye has continued to improve from finger counting 660, 624. That has improved. But left eye has gone down, I think, primarily because of the global ERM and sticky ERM there. That may have been the reason. Yes,
and the last, the cataract also.
Yeah, plus cataract also. That three factors are contributing. Yes, Pramod?
Because that one thing is typically when you are dealing with a tractional maculopathy, I think surgery should be the option. What he has indicated, he has very well shown. Yes, it takes long time to recover, definitely, but probably only anti-VEGF or trying laser may not work. When there is obvious traction, what he has shown, and I think he has opted well. I think surgery was the option, combining with, of course, cataract surgery. Cataract was dense enough. Coming to the other eye, injecting anti-VEGF, I would have been a little bit hesitant, particularly the photography shows having a ring-like thing and a lot of that fat proliferation on the retina surrounding the macular area. You are lucky, but I would say there's always a risk of getting contraction and whole thing getting lifted up. You are lucky enough now. I think now significant cataract is there, but still looking at the fundus picture, what you can see now, and looking at a cataract, counting finger vision does not correlate again now at this stage as well, because like a view is reasonably good enough, and going down from 660 to counting finger, there is something more additional ischemia and derangement of, I think, retinal output. Because you look at the OCT, probably you can't make out like a retinal structure well in the last OCT.
Yeah.
Yes, you can.
You see, Shalabh, the right eye, I think you were very aggressive in managing and you got good result. You see, you straightaway went for pre-op, anti-VEGF, did vitrectomy.
No pre-op, sir. No pre-op anti-VEGF.
Okay. You don't believe in giving pre-op anti-VEGF, or?
So not for this case.
Not for this case.
Because you already have this traction.
Yes.
You know that the anti-VEGF will not work in this case.
Yeah. And but left eye, what is your plan now? You want to
the left eye actually the patient was very hesitant to undergo any surgery, because for him the vision in the right eye took a very long time to get better, and he was not very happy with whatever was going on in his left eye also. he said
So
that.
what is the plan ultimately? Whether he agrees or not, that's it. What is the game plan?
Any associated optic nerve pathology also is there, because sometimes the disc may not give us any clue. And but I have seen some of the cases of these DMEs, and ultimately, if of course, if the visual acuity of good enough, we can do fields. Otherwise, even in neuroimaging sometimes can give a clue, because CF and the presented case OCT is not correlating completely.
Yeah, don't forget optic nerve in diabetics, because if the vision, like Pramod also saying, the OCT picture as well as the fundus picture, finger counting vision, maybe if you are 660 or then okay, but finger counting is slightly difficult.
So because as Dr. Pramod mentioned about the anti-VEGF with that ring-like structure, yes, that is why I did PRP first and then I gave anti-VEGF. So I think straight away giving anti-VEGF would have resulted in a TRD, bad TRD, as Dr. Pramod mentioned.
Yeah. Yes, Saurabh?
Sir, from the cataract surgeon point of view, I will go back to why this meeting for the webinar for them. My only advice is this sudden itch to do a cataract surgery and then send the patient to the retinal surgeon should not happen in these cases. If any of these eyes had a cataract surgery only initially, and telling the patient to isko pehle kar dete hai, then we'll send you to the retinal surgeon after that, will horribly worsen the case. So my request to all cataract surgeons, do not touch the cataract in these patients. You will make absolute mess of the whole situation. I know I'm being a little bit rude.
You're making them our enemy.
I know I said I'm making them a little bit rude, but sir, it does happen. All of us see patients every once.
Amit has already started shouting. So what I am saying is, you see, except for the first patient presented by Dr. Arvind Gupta, rest all the patients, moderate NPDR or PDR, have to first have a clearance or whatever by the retina colleague. Unless nowadays young people are can do both retina as well as cataract. But Dr. Rosha, what would have been your management about this patient? Anything different from what Shalabh did?
No, I agree pretty much with everything I have done. I agree that if you can have a view to laser and treat the posterior pole first to do cataract is very good, because if not, you can have iris neovascularization very easy. And many patients do cataract, get better, and just we lost follow-up. And when you come back, you have a glaucoma, neovascularization and glaucoma. And the vitrectomy for traction, that's evident. And I do laser first, and after that injection, because the contraction can make detachment. I agree almost everything you have done with this case. And the second case, I think now we need the cataract surgery, because it's hard to see the back of the eye to treat.
So Giri, now the approach should be what? Whether patient agrees it's a different, what should be the approach for the left eye? Left eye should be combined surgery?
As far as the left eye is concerned, I think visual prognosis is very poor. That's what I feel. Because as far as combined surgery is concerned, his OCT does not show any traction of the macula. It's more of a macular edema. And probably there is significant macular ischemia. Or as Padmaja said, whether there is any optic nerve, this thing. So visual prognosis in the left eye, after explaining the visual prognosis, probably if the cataract is quite significant, or if there is a significant posterior subcortical cataract, that's something which we see in diabetics. Probably I may advise first a cataract surgery, reassess, and then do a vitreous surgery. I may not probably go and do a combined thing together, but do a cataract, reassess, and then if necessary, go ahead and do it.
Yeah, I would tend to agree with this approach, because since the vision is not commensurate with all our findings, best is to let cataract surgery be done first.
Yeah.
After a couple of days, weeks, reassess the entire situation, maybe do an opta or an angiography to assess the ischemia, as Padmaja was saying, and as Giri also. So, and then counsel again, because then we can talk in raw language that the blood supply is deficient. If the blood supply is deficient, the tissue is dead, and hence the recovery may not be as per patient's expectation. So, any other comment? Yes, Partha, long time.
Yes, sir. So, it is the retina surgeon's day today, and we cataract surgeons have to sit back and just think that, oh my God, what have we been doing with all these diabetic retinopathy patients? So, but again, from the cataract surgery point of view, I think one or two very important take-home messages are there, and so many diabetic patients need to be operated. So the SDOCT, and which has been proved beyond doubt in the Cochrane review in 2015 and all. So it is a must for the evaluation of a diabetic retinopathy patient post-operatively and pre-operatively.
Pre-op more important. Pre-op actually more important so as to counsel.
Yes.
Post-operatively definitely you will do because the patient vision will not improve in any case.
The other things, Shalabh's case, in which there was an element of the membrane, the ERM was there. If the ERM was not there, and if it was just diabetic macular edema, center involving diabetic macular edema, would it be prudent to treat with anti-VEGF, have a flattened retina, have a flattened macula, and then go on to a cataract surgery with this in mind that possibly the anti-VEGF treatment might go on and might be required?
So with this kind of membrane, most likely the anti-VEGF alone will not work.
Without the membrane, Shalabh. I mean, we are talking about the scenario where the membrane is not there, and it
You
is
can
just
combine your cataract with an anti-VEGF. That will be better.
right.
And what is the anti-VEGF of choice, Sharaf, for you? Suppose there is no membrane, no traction, but PDR with macular edema you are doing. And what anti-VEGF you tend to use in such situation? Avastin or Razumab or
No, I prefer not to combine a cataract surgery with a multi-dose vial like Avastin, because then you can have endophthalmitis and you will not know what has caused it. So it's better to use a single dose, either the ranibizumab, either the biosimilar one or the eccentrics.
So this brings me to one question. May I ask all panelists present here, except Dr. Rosha, is the role of biosimilars, because all of us use injections in diabetic, even the second case which was presented by Dr. Gopi, the choice, does it necessarily remain Eylea or Lucentis, or biosimilars in your, judgment have equal kind of efficacy and safety? How often do you use biosimilars? Maybe we'll start from Kim and Giri and Bhinde. Is your practice of biosimilars same as the originator? Or? Yes, Giri?
Yeah, I think the use of biosimilars is definitely increasing.
Yeah.
It's increasing. I mean, it's much more than what we were using about a year ago.
So today, can Kim with confidence, can you use all these biosimilars which are available? Because we have in India, you see a lot of companies are coming up. Even I've heard a lot of.
Yesterday we had a very interesting session on biosimilar, Lalit. I mean, it was quite a good session. And a lot of data was presented from India across major eye hospitals where they have analyzed quite a few hundred cases, and they have shown that of late there are no issues with biosimilars. So I think the use of biosimilars is increasing. Yeah.
Yes.
Kim.
Especially because of the economic point of view. Very often it's not you who are deciding, it's the patient. You're giving the choice to the patient. And of course, you tell them what is the, what is your preferred choice, but then, the choice is obviously determined by his economic status. And more so that now that the biosimilar, especially Razumab, has been priced very close to bevacizumab, I think that is being taken up very frequently than any other drug.
You see, at our place, Center for Sight, we couple of years back we had say 5%. Now the usage of biosimilars has jumped from 5% to nearly 40-50% of all patients who are advised anti-VEGF. So that slowly and slowly confidence level is increasing. Saurabh, Pramod, any comments?
I'm quite comfortable actually. We are routinely using, but what Dr. Kim said, like we give choice to patient, including even Avastin also. I give totally choice to a patient. He chooses. We tell them that these are 3 or 4 options are there. and whatever you would like to, you choose it. But we are very comfortable with biosimilars now. No issue at all. It's like any other original molecule.
Okay, I think we'll move on to the fourth case scenario. After having covered NPDR, 2 patients, and PDR by Dr. Shalap, we move on to further complication of PDR, that is vitreous hemorrhage. You see, a lot of these patients may present with sudden loss of vision. So there's another message then for a TSM surgeon that any diabetic who presents sudden loss of vision, don't hurry for cataract surgery. Evaluate the posterior segment. So we have with us Dr. Alok Sen, a prolific surgeon from Chitrakoot, and he will be talking to us about this case scenario of diabetic cataract surgery in a patient of vitreous hemorrhage. And Alok will be introduced by Dr. Amit Porwal. Amit?
Yes, sir. It's my proud privilege to introduce my colleague from Madhya Pradesh, Dr. Alok Sen. He is a medical superintendent and the head of the Department of Vitreoretina and Uveitis in Sri Sadguru Netra Chikitsalaya, Chitrakoot. He is an all-rounder. He's an anterior and posterior segment surgeon as well. He's got a vast experience of handling complex cases in general ophthalmology and especially vitreoretina and uveitis cases. He has presented his academic work at various national and international forums, and is a seasoned player for various complicated cataract and retinal surgeries. So it's my privilege to introduce Alok, a friend of mine. So before I hand over the podium to Alok, a small request to all the panelists. This is a case file series. I request after each and every case, please do give all us cataract surgeon a take-home message for various types of diabetic retinopathy. When do we refer? How do we have to go ahead? What I'm feeling is retina is being discussed, but as a cataract point of view, I would like to know when to refer to you all, when to involve you all in my cases. Thank you. Alok, over to you.
Yes, Alok, we can see your slides. Alok, you can unmute yourself.
Am I audible, sir?
Yeah. Please carry on.
So thank you, Dr. Amit, for your kind introduction. Thank you, Dr. Partha, Dr. Lalit, for giving me this opportunity. I'll be presenting a very short case of a patient with cataract and vitreous hemorrhage. And this patient who presented to us way back in 2014, and this was 56-year-old male who had diabetes for 15 years and had received Avastin twice elsewhere in August and October. And he presented with vision of 5/60 and had NS1 cataract with what looked to us as a severe NPDR with a lot of blotch hemorrhages, dilated veins. And there was not much of macular edema. And we did angiography, and that revealed new vessels. So there was extensive capillary non-perfusion areas. And you can see that the periphery also shows early neovascularization with capillary non-perfusion. There was not much of macular leakage or edema. Patient with PRP and couple of injections of anti-VEGF. However, as it happens in India, this patient was lost to follow-up and came back in 2015 with this picture of vitreous hemorrhage, that a sudden diminution of vision for 3 days, and the vision had dropped to 1/60. The peripheral retina was visible, and you can see the previous laser scar. We asked the patient to ask the patient observation and to review after 15 days just to look for whether the vitreous hemorrhage resolves by itself. Again, the patient was lost to follow-up, and the patient came back in 2017, and this time he had a sudden diminution of vision, and this has not improved since 1 month. And he gave the in a history that he had a couple of similar episodes, and every time the vision had to improve, but this time it hasn't. And the patient on examination, he had a vision of 1 FFC with PSC and a vitreous hemorrhage. So this time we advised him a combined cataract with vitreous surgery. And this is a small video of the same. So the cataract surgery was as routine, clear corneal temporal phacoemulsification with an foldable acrylic IOL implantation. And this was followed by a 25 gauge pars plana vitrectomy. You can see the vitreous, organized vitreous hemorrhage there. And as you can see that the retina was well lasered, and there were few focal traction along the superior arcade, and there was a broad traction nasal to the disc. So a segmentation and delamination of this traction was done, and the oozing vessels were lasered. We checked the periphery, and the vitreous was trimmed, and the hemostasis was achieved, and we did do a little bit of diathermy to the front. And this is the first post-op day. There was a little bit of ooze. The cornea was clear, loose blood. The vision had improved to 636, and this is after 2 weeks of surgery. And you can see that the vision had well. And nasally, you can see this front which was dissected out. I think the case is open for discussion.
Thank you, Alok, for a brief presentation and a nice video. The message very well conveyed. Let me start this discussion primarily by asking our LTS7 colleagues, how will they approach? Suppose a patient gives a history of that he has been lasered, as Alok had said, lasered diabetic retinopathy with cataract comes. So what will they do? Let me start from our chairman Partho, and maybe then others can pitch in.
Yes, sir. Thank you, sir. So a patient who has been lasered and is a known case of PDR and has cataract. The first thing is, of course, the macular examination by the SDOCT and to understand whether there's macular edema, treatable, not treatable. And then if the cataract becomes significant, then to go for the cataract surgery, and with the vitreous hemorrhage, go in for the combined cataract surgery. At our center, usually the cataract surgeon does the cataract surgery and the VR surgeon does the vitrectomy part. So this is usually what the norm is.
So, but Dr. Porwal, Amit, how will you approach? Will you, do it yourself first and then refer? I'm specifically asking for people who do not have the VR surgeon and the team together, or you are not very confident of doing posterior segment surgery. Yes, Parikshit.
No.
So generally we do it together. Oh, please, Dr. Amit, go ahead.
Yeah, go ahead, Parikshit.
Yeah.
We would generally do it together, sir, because then it is done in a single sitting. So that makes it easier.
So I'll come to the complexities of usually doing together. That actually, to my this thing depends on the amount of job to be done in the vitreous cavity and how confident you are for the cataract surgeon that he will give you a nice dilated pupil at the end of surgery, so as not to compromise the. Yes, Saurabh, any comments from cataract surgeon point of view?
For all cataract surgeons and retinal surgeons, most of us see the patient dilated in our OPD, in our clinic when the patient is inside. I insist that the surgeon himself does a gonioscopy and looks at the iris very carefully for very fine new vessels in a patient of vitrectomy with cataract, because if you miss that by any chance, you are going to be in a disaster after doing the vitrectomy also. Patient will end up having NVG, very, very high chances. So any patient with vitrectomy with cataract, do a gonioscopy yourself and see the patient on very high magnification slit lamp before taking a surgery.
Yeah, point well taken.
Lalit sir, what I wanted to know is everybody is stressing. Now, when you get a case of cataract with PDR, if you have a retina backup, if you are having an institute practice with a retina surgeon around, you of course take a retina opinion and then decide if it's a combined surgery. But for a solo practitioner who's practicing cataract surgery in a city,
Yeah.
What would be a take-home message for him? Now he doesn't have a retina backup. He's not having. There are not many retina surgeons also in few cities. So when he comes across with this type of cases, how he's going to supposed to do? Does he supposed to
So
do the
my
cataract
question
and
was,
refer to retina?
my question was in reverse. I will ask you, what do you do if a patient comes to you lasered by, Alok Sen? He has done the laser, patient has a cataract, but patient has presented to you. What will you do?
So in my setup, I'll always take a retina opinion, and then based on the retina surgeon's opinion, whatever he decides, I'll go for a combined surgery or no.
So the message for a TS segment surgeon would be that not to rush for cataract surgery in this. Evaluation is very, very important. Either you do it yourself or ask your retina colleague to do it, or maybe refer for a retina opinion and then do the cataract. And
so may I add something?
Yes.
For a cataract surgeon, if he is fairly advanced surgeon, which means that he is more proficient, the presence of vitreous hemorrhage will not hamper the cataract surgery.
Advanced, all of them are advanced. Yeah.
No, I mean, doing a phaco in a patient who has a vitreous hemorrhage, you don't have a glow.
Yeah.
You may end up creating complications.
Yeah.
So your efficiency should be at a very high level, and then you can take up this case at separate sittings.
And I would do agree with Dr. Sairo's comment that we should do a gonioscopy whenever you have a PDR. That is a must for all anterior segment surgeons, cataract surgeons, that we should not forget to do a gonioscopy. If any sign of NVA appears, if any minute vessels are seen, then it is an indication that it is not only in your domain, the case has to be discussed with the retina surgeon for a complete PRP or an injection, whatever.
Yes,
a couple of things I would like to add here. When you know that you probably at the same sitting or next sitting, next few days, you may need vitrectomy. So I will be hesitant using clear corneal section in these eyes. Probably I will go a little bit backward and have that section covered up with the conjunctiva, because if at all I had to take for surgery later on, I'm more comfortable. Also with a clear corneal section, risk of endothelial, of course there's good cataract surgeon, they are very comfortable, but risk of endothelial damage, corneal edema, that is added issue. That is one thing. Second thing is, depending on amount of vitreous hemorrhage you have, like the case what you have described, him was not that significant. You turn the eye to a little bit one side, you get enough glow to do your rexis well. That is one thing. Second thing is probably the simple thing what you can have, you can keep your something, our endo illuminator, what we use for VR surgery. You do not have to use inside the eye. What you can use, have it with you, and while doing rexis, just hold it in an oblique illumination. Probably in between, I'll search like hardly a few second video I have, if I can search for in between. But that gives adequate illumination for you to see the edge of your rexis, and probably you are more comfortable, much more control you will have if you use a forceps to complete rexis rather than using a needle to rexis. Of course, again, its proficiency, what Salab is repeatedly telling, proficiency of cataract surgeon, how comfortable they are using with those instruments.
Yes, Sonu is another proficient cataract surgeon we have. So he was writing the chat box about staining. Yes, Sonu, any comments about this?
I think definitely with vitreous hemorrhage, cataract surgery becomes a little difficult because you don't have that glow. So I would always recommend that staining should be done well, and no cortical matter should be left because you can't really see. And I think that use of endo illuminator, maybe through that side port you can use, and that can be a good aid, for complete cortical cleanup.
And Lalit,
yes.
One point Amit is that he was asking about referral. I think wherever there's no vitreoretinal surgeon in a town or a city, I think they have to find a way how to evaluate a diabetic patient. For example, they're in a small town and there's no OCT, there's nobody to see. I think you have to educate the public also that you need a retina checkup before you do the cataract. So maybe whatever distance, I think there will be some distance where the retina surgeon will be available, and they get an opinion and then go back to the cataract surgeon.
Yes, Dr. Kim, you were saying something?
No, I was just going to add to what Dr. Pramod said regarding the cataract surgery itself. Like, apart from the avoiding corneal incision, also doing instead of a temporal incision, doing a superior incision is much preferable if immediate vitrectomy is planned in these cases. So that's.
Any other point, Prashant, you would like to add in this? Cataract surgery to be done in patients of PDR with vitreous hemorrhage?
So from retina point of view, also would like to know which IOL you would recommend as a retina surgeon for us. What would you recommend? Hydrophilic, hydrophobic, or a BMM lens?
So therefore, I was asking Prashant because he does both.
It's always a hydrophobic is preferable. Definitely no silicon IOL, I would suggest.
And no multifocal also.
Yeah.
No multifocal preferably, yes.
So,
Sir,
I
just a
think,
comment, sir. Sir, in Alok's case, there was, we saw there was a little bit of ischemic maculopathy. So one pertinent point is in a patient with ischemic maculopathy where you need to give an anti-VEGF or there is macular edema associated with the ischemic maculopathy. So what is the preferred anti-VEGF, or would it be an intravitreal dexamethasone?
Alok, like to react to this?
Yeah, I don't think there was ischemic maculopathy in the case. There was peripheral ischemia, but not in the macular area. There was not much of edema when we saw the patient for the first time in 2014. And I basically presented this case to highlight that some of these patients, we have done lasers, they keep coming up with the recurrent vitreous hemorrhage, and that those hemorrhages are basically because of traction and not because of any new vessels which are coming up new. So they may not be treated by intravitreal anti-VEGFs, and also they would need vitreous surgery rather than treating with anti-VEGF.
Yes, Saurabh.
Alok, particularly not for this case. I'm saying the case
So,
with ischemic maculopathy, in which there is macular edema, center
There is no
involving
harm.
macular
There is
edema.
no harm in giving
there is
anti-VEGF.
no harm, sir. Yeah, there is no harm in giving anti-VEGF, although we don't have evidence on treating ischemic macular edema as such, but we do treat edema with macular ischemia with anti-VEGFs, and there are no as such side effects of anti-VEGFs causing further ischemia or further loss of capillaries.
You see, Partho, there was the initial hitch in, injecting anti-VEGF in patients already having ischemia, of the possibility of worsening of ischemia. There were stray reports, but those are no longer true. Frankly speaking, it does not exaggerate ischemia if you give anti-VEGF in such patients. Saurabh, one last comment from you.
Partly responding to Amit Purval's question, if you are an anti-segment surgeon, patient has a lot of faith in you, you find vitreous hemorrhage, advise on ultrasound to be done, try and interpret the ultrasound yourself with the extraction, then you have to get rid of the patient early to a VR surgeon. Minimal vitreous hemorrhage, you know what you're looking at an endoscope. You can wait for 2 to 3 weeks. My question back to you, Lalit sir, specifically only you, so you can answer the last question. Cataract with vitreous hemorrhage, how long will you wait before advising vitreotomy? And please understand, our main audience here is cataract surgeons.
You see, my threshold of waiting has decreased quite a bit. If patient like in Alok's patient had a history of improvement because of the previous laser which was done. But I normally tend to intervene within 2 to 4 weeks now. Because especially in one-eyed patient, especially if patient has not been lasered, and especially if, first follow-up does not show any improvement. If suppose vertically follow-up, I say I have seen today, I'll see him after a week or 10 days or 2 weeks. If suppose there is resolution, I may add laser through LIO in such patients just to, because laser dyes always do better with the vitrectomy than non-laser dyes. So my threshold because of MIVS has decreased quite a bit from the traditional 6 to 3 to now maybe a month or so.
So 1 month, let's have a take-home message. 1 month is the outer limit or a limit at which you can talk about surgery. I think that's very important to cataract surgeons.
Yeah, I think threshold has decreased. I think that everybody will agree because of the
Lalit, one more information in this is these are the patients who tend to lose for follow-up because they know after some time their vision will improve.
Yeah.
And they kind of keep on prolonging this over a period of time. Like in Alok's case where the patient has recurrent vitreous hemorrhage and improvement in vision. So that we have to be aware of.
So the other thing I think somebody is asking in the chat box, cryo. Cryo, I think, has taken a back seat after laser and wide-angle viewing system. There was a time when wide-angle viewing systems were not there and we used to do peripheral cryo in such patients. But nowadays, I think it has taken a back seat. Let's ask Dr. Usha about this cryo efficacy in patients of PDR. Rosha, any opinion on that? You have to unmute. Yeah.
Currently, I'm not doing more cryo in diabetic patients. I use only laser or injections. Cryo is very aggressive and can make more damage than good. And this case was something that every time the patients postpone to treat, they can come with neovascular glaucoma or tractional detachment, and they end very happily, but many cases we lose during this loss of follow-up, because every time the patients disappear, and when they came back, they can come with glaucoma. And then I try to push, do cataract, and sometimes do Avastin first and vitrectomy in 2 or 3 days, not more.
Yeah, I think early intervention always gives better results, as Saurav was trying to extract from me, that early intervention in all these patients of PDR with vitreous hemorrhage, you see, gives better results compared to if we keep waiting. And as Dr. Kim said, if you wait, sometimes patient may be lost to follow-up for a long time, and ultimately visual prognosis may get hampered. I think Padmaja had one point. Padmaja?
Yeah, I was mentioning about mainly when in case of anterior highlight proliferation, because these are the patients who can last for follow-up, and they can come with recurrent vitreous hemorrhages. And that time when you do cataract surgery, when you see the periphery, how much ever we do clear the vitrectomy and do laser up to periphery, sometimes we may have to go for resort to those particular cases. We should go for cryotherapy as well, and as well as adjuvant anti-VEGF injection.
Yeah, aggressive laser has to be done in such patients. Okay, we'll move on. We'll move on.
Sir, can I ask a very simple question from the cataract point of view?
Yes.
If in one eye you have a total white cataract and the other eye you have a frank, macular edema, what would you do with the cataract? I mean, would you just take it? I mean, would you just do a phaco? And how would you know the status of the eye in which the cataract is there vis-a-vis the macular edema? Can you extrapolate that what is happening in the fellow eye is also happening in the eye with a white cataract?
So let me pose this question to Dr. Pramod about what Namrata is asking. That one eye has total cataract.
Yeah. So basically, there are two different scenarios here, and what Padmaja already posted. If we are having active diabetic retinopathy or macular edema, which you are having in other eye, but view is there, aggressively, I would treat that in that eye simultaneously, delay cataract surgery in that eye clearly, relatively clearly. But if you have a white cataract, you can't see anything, you just do not have choice. You just, I would say, go ahead with cataract surgery, but obviously anterior segment assessment, rule out there is no iris neovascularization or angle neovascularization. Take care of cataract, and probably I would say on table, you evaluate the fundus. Suppose you feel there is a retinopathy, there is a macular edema, I won't hesitate giving intravitreal anti-VEGF on table to that patient. And definitely within next few days, I would refer that patient to a retina colleague to take care of further management. And depending on stage of retinopathy, retina surgeon will handle subsequently.
Yeah, pre-op ultrasound could be added to this because
ultrasound, assuming that what madam said, assuming that retina is attached while looking at it, that's what I assume that way. But yes, the basic evaluation will be done always.
Okay, I think we'll move on to the next severe case scenario, and this will be presented by Dr. Mohit Dogra, a consultant at Chandigarh. And Dr. Mohit is again a very versatile surgeon. I have seen his videos and presentations, and he will be talking to us about scenario where there is a cataract plus there is a rubiosa iridis. And may I invite Dr. Parikshit to please introduce Mohit.
On behalf of the scientific committee of the All India Ophthalmological Society, I would like to introduce Dr. Mohit Dogra. Dr. Mohit is a young star, as you can see. He has done his master's in ophthalmology from the prestigious Postgraduate Institute of Medical Sciences, Chandigarh. and he has done almost 5 years of specialty training in vitreoretina and uveitis from the same institute. He's won numerous awards, including the Best Surgical Video at APVRS in Seoul, the Prem Chandra Best Free Paper Award in the North Zone Annual Conference, and also an award in the HPOS Annual Conference. In a very short span, he has authored 48 publications and 14 book chapters and is a reviewer for numerous international journals. Dr. Partha sir and Dr. Lalit sir have a fantastic lineup of young stars as presenters for this. So we look forward to hearing from Dr. Mohit Dogra. Over to you, Dr. Mohit.
Thank you, sir, for the...
Yes, Mohit.
Thank you, sir.
You see 50 publications in such a short span. Congratulations. Please carry on.
Thank you, sir. Thank you, sir. Thank you, Dr. Parikshit, for that lavish praise, which I think I don't deserve. And I'd like to thank AIOS at the outset. And also, is my, sorry, is my arm a slide visible?
Yeah, carry on. Everything is visible.
I'd like to thank...
we can hear you.
Thank you. I'd like to thank AIOS at the outset, and in particular, Partha Bishwas sir, for actually giving me this opportunity. I actually had just one case to present, but during the course of the discussion of the last case, which was, I think, excellently presented by Dr. Alok, I added a second case. I took that liberty, so apologies for that last-minute addition. I'll make sure that I finish in 4 minutes, since my original case was just a couple of minutes. So this is actually case 1, which was supposed to be the original case. So a 54-year-old male who was a type 2 diabetic for 10 years, on insulin for those 10 years, and on oral hypoglycemic for 10 years, and was recently started insulin 3 years back. He complained of decreased vision right eye since 1 month, which was associated with redness. He had a history of amputation of 2 toes of his left foot 6 months prior. Also had what his records actually showed, a left uncomplicated phaco plus IOL 2 months ago. Also had 2 sittings of PRP as per the notes that this was done elsewhere, and had poor visual acuity gain, and also had pain since the last 15 days. There was no history of, chronic kidney disease, any cerebrovascular or coronary artery disease, no history of receiving intravitreal injections, and no history of lasers in the right eye. Now, I'm just going to be presenting photos after this. So that's at presentation, that's the right eye. So there was an acuity of 6/60, and the intraocular pressure was 26. And you can see these NVI there, along the pupillary margin, and there is some cataract. That's the view of the posterior segment. The patient had macular but extrafoveal pre-retinal hemorrhage. And that was the OCT, which showed that there was no edema. There was a localized posterior vitreous detachment. And, there was some blood in that kind of subhyaloid space, and you could see that blood there. That was a left eye presentation, which had undergone cataract surgery with non-gratifying results. That was counting finger close to face. The IOP was 38, and lo and behold, you can see all of those, much more franker, if I can call them, new vessels at the pupillary margin. Also had florid NVA, as was alluded to in the last talk. I think, Gonio helps you with that. And, they were all over the angle, and although the angle didn't seem zippered shut as it can do in like the last stage of NVG, that was the back of the eye of the left eye. And that was the ultrasound. So again, showed some vitreous hemorrhage. There was no PVD, and there was like a flat FVP with no traction of the macula. That was the angio of the right eye. And I must admit here that, I put this in for the sake of this presentation. I think if you have NVI in front, you don't need it's not rocket science to diagnose that there is gross PDR at the back of the eye. But, this is just for a visual impact. So, the posterior pole looks fairly okay as far as the, angio goes. There's a extramacular upper temporal NVE, but the temporal macula you can see is completely knocked off. And you would expect considerable amount of ischemia at the back of the eye for the patient to have those amount of NVIs in front, right? And this is just to show one of the new tools on the block. So if you don't want to do this, you can just do a wide field, non-dye based OCTA, which will, show you similar things. Again, not a mandate, just for academic interest and for this, presentation will clearly show those capillary dropout areas and, all of the other changes. So what this patient actually underwent was, so I did extensive right eye panretinal photocoagulation first sitting right on that day, and did a random blood sugar, and there was some discussion regarding the choice of anti-VEGF. We at our center have not been giving intravitreal bevacizumab for close to 4 years now, and since economics come into them, the Intas biosimilar Razumab for me, at least for for these pre-op diabetics, PDR with your NVI is my anti-VEGF of choice. So that's what was done, and a week later I completed PRP in 2 sittings for this eye. The left eye was started on anti-glaucoma medications and cycloplegic same day, and there was prompt. The emphasis was on promptly getting a clearance from the physician, because the person had actually undergone a couple of sittings of PRP in that eye, albeit it was inadequate. Despite that, the quantum of ischemia at the back of the left eye was so much that they were NVI and was vitreous hemorrhage and a little bit of traction. And I did not, as has already been discussed, you can't inject without getting physician clearance because you don't want a crunch phenomenon to occur. Although I think in this it was a little less of a concern, but getting a clearance was the mandate, which luckily we got. And I injected intravitreal Razumab, again my anti-VEGF of choice in PDR HRC cases, and waited a little longer. Hello.
Yeah.
Yes.
Fine. Yeah, carry on.
So, and I waited a little longer than usual. Normally, I wait about 3 days post, anti-VEGF, but I waited 5 days because I wanted, there's no data on this, but it's just my preference. If they have that flowed amount of new vessels in the iris and the angle, and then went ahead with PPV. The right eye underwent, phacoemulsification a couple of months later, and this is just the last slide of this case. So this is the right eye, at the end. And one thing that needs to be highlighted is you saw the cataract at presentation wasn't that dense, hence we could get that good quality photo and that fluorescein angiogram. Couple of months down the line, these cataracts tend to progress a lot faster than what your routine age-related senile cataracts would. And by the time we reached this stage, there was close to just about no view of the fundus, very faint view, but he did fairly well after cataract surgery, and that was that. I'm just going to quickly go through the second case also, because I've taken, this was just, I put this in at the last moment. I had this for a long time, but I think the discussion in the last, as I had said, case actually made me do it. So this was a considerably older gentleman, 73-year-old, type 2 diabetic, 15 years, underwent a cataract surgery, and lo and behold, we talked about this, got a multifocal in the left eye 2 months back. Grossly dissatisfied, went from one place to the other, which I'll be highlighting in the next 4 slides, and was advised multiple times to undergo right eye cataract surgery with a multifocal IOL to get rid of his symptoms. So that's center 1. This was as per the nose he was carrying. The IOP was noted to be 34, 32 right and left eye, was put on maximum anti-glaucoma medication therapy, including Diamox, and was advised multifocal at that sitting. Went to center 2. Then they noticed new vascularization in the angle. Someone was smart enough. They did a gonio. The intraocular pressure was 8 and 10. Since he was on oral Diamox and all the AGMs, he was advised to continue same treatment, but advised multifocal IOL one more time. This is case. He went to center 3. At this point in time, he had, again, this is what his note said, and they said that there's no NVA. And there's just NPDR DME, and was invited to write phaco with foldable IOL, and they said no, we were not going to put multifocal IOL for you. And this is finally center 4 before coming to us. So this is so he had a best corrected visual acuity 612, counter finger 1 feet, IOP 19 in the right eye, and left eye was raised, and it said in the note that the patient had missed the that day morning dose of Diamox. Both eyes had florid, as per what they said, iris neovascularization, and was referred urgently to us. And that's what we saw when we saw, so that's your routine magnification slit lamp exam, right? 20/40 both eyes, was at this point in time on oral capsule, IOPAR SR, and a couple of AGMs. Left eye had that. That's the back of the eye, right and left. That is the front of the right eye. You can see those NVIs there. The cornea is clear, mind you, and that's the front. That's the front of the left eye, which has the IOL, and you can see those very clearly visible in the non-dilated pupil INVs, and that is your multifocal IOL in that eye. And that's what the fundus showed. Had a little blob of hemorrhage there. That's what that showed. The back of the eye, at least on the wide field imaging, doesn't look that bad. The angio will tell you a different story because there is new vascularization of the disc. There is quite significant capillary dropout in the periphery and multiple NVEs, which leak in the late phase. The right eye looks a lot lesser, and you must understand that anytime PDR or anything gets kind of complicated by even an uneventful cataract surgery, the quantum of the background diabetic retinopathy, be it PDR or NPDR, will increase. So hence the left eye, in my opinion, showed a much advanced picture, and that's what the right eye showed. So a small NVD or NVE doesn't look all that bad. For lots of people would just call it a non-HRC PDR if they would not look at the NVI in the anterior segment. So the quantum of ischemia was considerable, and again was managed with both eyes, extensive pan-retinal photocoagulation. The left eye also received the anti-VEGF. The right eye did not, and the patient eventually did fine. Thank you.
Thank you, Mohit, for excellent presentation. And also, the second case, I think, has a lot of messages for the anterior segment people. Because you see, this story is not uncommon, that cataract surgeon rushing for IOL surgery. You see, the fact that you had very nice angiograms itself proves that there's no rush for cataract surgery. The quality of the angiogram which you showed, the NVD, NVE ischemia very well visible. So what to talk of multifocal, I would suggest to all cataract surgeons, don't hurry up. Patient already has NVI, NVG. So rush should be for PRP, aggressive PRP in both the eyes. And like Padmaja was saying, right till up to maybe beyond vortex vein and up to ora serrata, then only this patient will have good quality of life all through his life. And if anybody does cataract surgery, I think they'll be doomed for the patient. So message for cataract surgeon is do not rush at all, especially in patients who have NVI, especially in patients who have so much ischemia. Let the job of PRP and laser coagulation be completed. That is, I think, the bigger messages compared to the first patient you had. So this case is now open for discussion, and we have
point.
Yeah, one second. Dr. Kim and Dr. Prashant and Dr. Giri will be discussing. Yes, Nati, what do you want to say?
Well, I just wanted to say quickly, excellent cases.
Yeah.
Two important lessons which I resident is to make a note in diabetic patient, no rubeosis as also a finding after slit lamp examination, which is very important.
Yeah.
I think it's really found out. And then the wide field angiography shows the capillary dropout, which we have to keep it in mind whether you have a wide field or not. And the other is I actually tend to use if there's the NVI to do anti-VEGF and then do the laser also.
Yeah, I think we'll discuss that. I think Saurabh already pointed out about gonioscopy in all diabetics. To mention, you have emphasized that it should be mentioned. If it is not there, also mention that it's not there. That is again point well taken. So Dr. Prashant and Dr. Giri, please.
Yeah, Prashant, I think you take the lead. You have not been.
Prashant?
I mean, yeah, you've been very quiet.
Prashant is listening to music something. Prashant? आवाज नहीं आ रहा है.
Very nice cases. I think I'm glad that the team has included this combination of cataract with NVI, because the thing is that, I mean, unlike a CRVO with an NVG in a proliferative diabetic retinopathy has got very good visual prognosis and is a medical emergency. I tell in the hospital it's a medical emergency. Treatment should be started the same day, within a few hours. You shouldn't delay it. Don't ask the patient to come, and don't delay doing, fluorescein angiography, this, that, and all that stuff, and delay it by days together. So the patient comes, it has to be, yeah, Prashant, please.
Yeah. Am I audible, sir, now?
Yeah. We're waiting to hear you.
Oh, sorry, sir. In fact, I was learning from all of you greats over there. The thing is, not uncommon is this presentation where we see a new vascularization on the iris. Carrying forward the last discussion when we had in a last case over there, that you have a cataract, you have a minimal vitreous hemorrhage, and it is an unlasered eye. Usually the tendency is to wait for the hemorrhage to clear and cataract to permit the laser, and many a times we land up just waiting for the cataract or the hemorrhage to permit us a laser. And so in such cases, at least in unlasered eye, at least for most of the retina surgeon and anterior segment surgeons, the message should be minimal vitreous hemorrhage in a cataract, having a cataract associated with it. It is not prudent enough for us to wait for a longer period of time, even if it means a minimal vitreous hemorrhage. Now coming to Mohit's case number 1, that is right eye, NVI, yes, he did a wonderful job. We are very aggressive in our center that the moment we see NVI, especially if the pressures are high, what happens, the anterior segment surgeon refers it back to the posterior segment surgeon saying that it's your job. And the posterior segment surgeon keeps on saying the pressures are high, the media is not allowing me lasers. And that shuttling of the patient between the two departments lead to the loss of it. It's a medical emergency, as Dr. Girdhar has said, and it needs a joint treatment. In our place, our protocols are very set. If the media is permitting, fire the laser, blast off the retina, maybe 3,000 to 4,000 shots or whatever be. Even in a bad media with a high IOP, at our center, we do not do anterior retinal cryopexy, basically because it adds further to the inflammation and leads to more, probably our belief is that it might contribute more to VEGF and anti-inflammatory factors. So we try to do it with lasers. If laser is not permissible, and the pressures, in spite of maximum medications, are not giving you an opportunity to reach out to the posterior pole, just plain anti-VEGF is not going to help. Here you have to combine it a cataract surgery along with an anti-VEGF treatment. And many a times, if we see that the patient has been having a persistent high pressures of 30, 40 plus, we might even do a vitrectomy. So it would be a combined procedure where we do phacoemulsification with IOL with a vitreous surgery. And glaucoma procedure, depending whether he should be given a trabeculectomy with antimetabolite or a IMED glaucoma wall, depending upon the evaluation by this. So it means the carry home message is you have to be very aggressive. You cannot afford to wait for the IOP to come down in such cases. Otherwise, you will lose the eye.
So, Prashant, you do all these 4 together, like cataract and glaucoma and vitrectomy, and or you stage it?
Yeah, like as I said, sir, if it is
it's
a
patient of NVG, it's a patient of NVG.
Yes.
Where laser is not possible, and
Yeah, if the pressures, if the angles are open, sir, and if the media is not allowing us, then we will do just a phaco surgery followed by on-table LIO, that is laser indirect ophthalmoscopy.
Yeah.
But if the media is not permitting us anything like this, we will scrape off the epithelium and do phacoemulsification. Means if the patient presents with a high IOP, like Mohit's other eye had, though it had undergone a cataract surgery, but if the pressures were persistently high and media is not letting us do plain LIO, we might not hesitate going inside that.
Mohit,
if a patient has NVI, should a cataract surgeon inject an anti-VEGF and then try to start the anti-glaucoma medication, refer to the retina surgeon, or just start the anti-glaucoma medication and refer to the retina surgeon? Since it is an emergency, can you give anti-VEGF and then refer?
No, if you have got reasonably good knowledge of medical retina, etc., and if you're able to do good indirect, I don't think there's anything wrong in giving an anti-VEGF. Because if there's going to be a delay, suppose the patient is not going to reach the concerned doctor immediately, and there's going to be a delay, there's no harm in giving an anti-VEGF for the rubiotic changes, because the rubiotic changes regress within 48 hours after the anti-VEGF, and there is a dramatic effect as far as the disease is concerned, and the PRP can be given subsequently. I mean, there is no harm in doing it. But if you have a retina surgeon in the same place and the patient is going to reach the retina specialist within 24 hours or within a few hours, I think probably everything can be managed by the retina specialist rather than you doing something and the other person doing something together. So it may be better. Now, to add to what Prashant said, I think 1 or 2 points to what Prashant said. Number one is, if you see the cases of Mohit, very characteristically, the ischemia is more from the equator to the aura.
Yeah.
And that's a very important message. These are all patients who are having peripheral ischemia. Therefore, when we do the laser, invariably, we must reach that area. There's no use giving laser on the posterior pole. So the laser has to reach the ischemic retina. Therefore, you may have to combine your slit lamp indirect with some degree of laser indirect ophthalmoscope, as was explained by some of the surgeons. That's very important. Unless you do that, you don't reach the periphery. And that's why we used to do peripheral cryo earlier for NVG. But now with LIO, it's not necessary, number one. Number two is that if there is a cataract with the NVI in this particular case, fortunately, the cataract was not acting as an impediment to the management of the neovascular glaucoma in this particular case, which Mohit showed. But if the cataract is acting as an impediment for the management of NVG in the form of giving laser, etc., adequate laser, you do the anti-VEGF, give little laser, within a few days, do the cataract surgery and finish the treatment. Don't delay. Finish the treatment, because aggressive laser is what is a permanent treatment. Anti-VEGF gives you only temporary, effect. It's going to come back again. And regarding the intraocular pressure control, etc., developing of extensive synic, the need for vitrectomy is only when there is a vitreous hemorrhage. I don't think that we need to do a vitrectomy just for a rubeotic eye, the sort of cases which Mohit has shown, especially the right eye of the second patient. The left eye, of course, had a vitreous hemorrhage. It had a pre-retinal hemorrhage also. There was an indication for vitreous surgery. But otherwise, in a simple case of a PDR where there's only an ischemic retina with cataract and NVI, there is no need to do a vitreous surgery. They may need a glaucoma surgery, and glaucoma surgery can be combined with the cataract surgery. If there is
after how many?
Yeah.
You would recommend a cataract or a trap or a combined? I mean, in the case of NVI.
I mean, that's again a lot of, I don't know. That lot of things that come into this. Suppose you do the anti-VEGF injection and give some laser, and after a few days, the intraocular pressure has reduced. It's only 22, 23, or 24. It's a tolerable intraocular pressure. Probably only cataract surgery is enough. You don't need to do a combined cataract surgery with a glaucoma surgery.
The question is, after how many days of this anti-VEGF or PRP,
you can give it in 4 or 5 days.
regress, and then we can
within 4 days, 4 or 5 days. In fact, last week we did one case in our center. We did it within a few days, 4 or 5 days after, because it just regresses. You can do a gonio and check it up on the slit lamp, and 90% it would have regressed. You can go ahead and do a cataract surgery.
Rubiosis will go away in 24 to 48 hours. After that, you can plan. Because stress should not be on cataract surgery. Stress should, because cataract, if it is not too much, unless it is, white cataract. But by and large, if it's manageable to, even if LIO say, if you can put few spots also, 300, 400, that should be done beforehand. Rather than, you see, glaucoma is more important in such scenarios rather than cataract, because cataract is, generally not much. So therefore, I was going to ask Mohit, in the left eye of the first patient, you planned for vitrectomy after razumab for 5 days, but what about pressures? You see, nothing was planned for.
Yeah. So again, sir. So that was actually managed in consultation with our glaucoma people, and because that beautiful angle photo was actually courtesy them, and because they actually if they're able to, if the cornea permits, and so in so-called early NVG cases, they're able to manage a good gonio, indentation or otherwise, and they're able to, and they're fairly confident that the synechial closure, the so-called zipper closure, which happens all just about 360-degree in these patients, hasn't set in to the extent that they feel would warrant urgent anti-glaucoma, glaucoma filtering surgery. Then again, they also want to give 5 to 7 to 8 to 10 days of because this patient wasn't on any kind of anti-glaucoma medication prior, so they want to give a trial, and the this wasn't the stage 4 of the zippered closure of the.
But believe me, Mohit, these patients don't do well with medications. Ultimately, surgery is required for glaucoma in such patients. Let's hear Pramod Ghande. He was,
basically, also looking at the pattern and having what Dr. Girdhar also mentioned, that anterior segment is much more involved compared to when you look at the posterior pole. Unfortunately, he got a good picture there. There are not many changes. I would like to rule out ocular ischemic syndrome as well in these eyes. That is also, you have to look at it. You need to investigate this patient for that. Because considering amount of iris neovascularization you have, and practically posterior pole is almost normal. So, and your periphery has shown very well. I think I would definitely need to rule out. As far as cataract surgery is concerned, see, there are two issues. When you have an active rubiosis, you are bound to have hypema, bleeding during surgery, and that's the practical difficulties you have. So that part you can easily take care of. Anti-VEGF you inject within 24 to 48 hours. Vessels will regress, and if necessary, you can cataract surgery. But as rightly everybody talking about, that is not a priority here. Another practical difficulty is if IOP is high with the maximum possible medication, and again, operating cataract in that scenario, you are risking of, again, you are having a suprachoroidal and all these issues. So you need to give time to bring the pressure also down. So cataract take little bit second step. Priorities, get your neovascularization under control, get your IOP under control. Of course, it permits. And then, meanwhile, you add on some laser, even 400, 500 bus, whatever, as much you can. And as media keeps on clearing, see, as IOP goes down, comes under control, media also become clear, cornea clears, and you keep on adding some more laser if necessary.
Dr. Bhalla, glaucoma approach in such patients, any comments?
Yes, sir. That's what I like they're saying, that glaucoma in such patients is usually intractable. I think after you have given anti-VEGF, we need to, the second important step is to bring down intraocular pressure. Cataract can definitely take a backseat because the pressures definitely have to be brought under control. And then once pressures are lasers can be done and a patient can be continued on anti-glaucoma medication medically. But usually such patients do require surgery. So depending on the extent of neovascularization in the angle, these patients usually land up with the glaucoma filtering surgery, either with the mitomycin C.
Yes, Mohit, last comment from you.
Just had one thing to say, sir, if time for it. I think rightly pointed out by Pramod sir and Padmaja ma'am in the chat box also regarding
ocular ischemic syndrome.
Yes, and just to add one thing to make, so that normally we associate diabetes with microvascular complications because diabetic retinopathy is a microvascular complication. So we talk about nephropathy, retinopathy, and neuropathy, the triad, but it also has macrovascular complications which are responsible for a lot more mortality. So they get cerebrovascular disease, coronary artery disease, they get ischemic foots, diabetic foot, and this patient had amputation 6 months prior. So patients who get amputations have diabetic foots, and not just the regular ones which get away with control of blood sugars and regular dressings, but actually turning into gangrene and requiring amputation, have a much higher frequency of getting severe PDR disease and absolute knockoff of the periphery, as was seen in this eye, because I believe that's similar to a macrovascular thing on top of the microvascular that is being added. And just one other point, sir, I think someone just texted me on a personal number. They want to know about the panel's take on why not inject intracameral, since the NVI is in front. I
wanted to bring up this issue. I do wanted to bring up this issue.
Yes, sir. So as someone just texted me, so
either way is okay. See, either way is okay. Even if intravitreal have equally good effect, but you can see what happened. Why you don't want probably an anti-shake. Of course, his IOP is high. Cornea is steamy. Sometimes you are hesitant. But his either way is okay. Doesn't matter.
The turnover time in the anterior chamber is too fast.
Amit, the problem is the results. If you inject the vitreous cavity, iris usually melts away. Plus, the reason I don't advocate anterior segment is because somehow the cornea becomes bad for the cataract surgeon. It does not clear away so fast. Rubeosis may go away. Rubeosis will go. But somehow there will be a layered kind of small heme somewhere. So that is the reason, or endothelium may get compromised. So that is the reason, believe me, if you inject in the vitreous cavity for 3.5 millimeter behind 4 meter, rubeosis will definitely melt away.
So even when performing a trab in these patients, we do trab with MMC, but with intracameral anti-VEGF also added, the success of the trab increases in these patients.
Yeah, that is agreeable. But believe me, at our center, but I don't know about other places, the results of shunt in NVG.
Yeah, much better than the traditional trab.
Therefore, I wanted Bhalla to comment on this, because we have had more than 15-20 patients of such situations where we have done shunts as a primary procedure. Believe me, all of them, as Giri was saying, have reasonably good vision.
So I think I would like to add upon the place of injection. Hello. Yeah, I think regarding the site of injection of intravitreal for managing be it glaucoma or NVG or be it ischemia in the posterior pole, let us remember the primary focus of the disease is in the posterior pole. And so the intention, you have to inject into the vitreous cavity because you're not only going to do trap, but you have to hold back the osteopole ischemia by meanwhile you bring down the pressures for the retina surgeon. So that is why, Amit, it should be predominantly only in vitreous cavity.
No, I'm talking when we are doing a trab. You are given an anti-VEGF intravitreal, but when we are doing a trab with MMC, do combine with anti-VEGF in the anterior chamber, so the success of the trab increases. Another take-home message was rightly pointed. Everybody was after the other eye multifocal IOL. A take-home message for all the cataract surgeons: please don't go for a multifocal IOL in the other eye. It is not to be put. And again, the question I'm putting up in the chat box, taking into consideration the amount of diabetic patients we have, should we encourage multifocal IOL in all the diabetic patients, even though if they are not having diabetic retinopathy at the time of examination? I would request your panel to answer this.
One of the contraindications or relative contraindication for the use of multifocal is macular disease. Actually, this was told to me by my daughter. My daughter is just writing an examination. So she told me that one of the relative contraindications, apparently multifocals don't work with when you have macular edema, because one of my buccal patients who had a 6/9 vision after the buccal surgery had a cataract done recently, about 2-3 months back. And after I asked him to get the cataract and come back. But after cataract, his vision, he has put a multifocal and his vision is not improving beyond 6/24. So I was just wondering, and my cataract surgeon said that he said beautifully done and all. So, but unfortunately, the macula was not very good.
My question is, diabetic patients, no diabetic retinopathy, taking into incidence the number of the incidence of diabetic retinopathy in the diabetic patients. Today, a diabetic patient presents to me with no diabetic retinopathy but a significant cataract. Should a cataract surgeon encourage him for a multifocal, or because he's diabetic in the future, he might develop diabetic retinopathy? So just encourage him for a monofocal.
I would not.
That's the reason I want the panel to stress on this, that we cataract surgeons should not emphasize on multifocal.
Can I answer here?
Yes, sir.
Can I answer? There are two ways of looking at it. The act of cataract surgery, which induces the inflammation, generally worsens the retinopathy. So in fact, there are new way people are thinking, even lens is reasonably clear, and if you do not have diabetic retinopathy at all, that is the best time, do it of cataract surgery, do conventional thing. Even if you want to put multifocal oil, go ahead that way, because you are done with that, and your patient period of 6 months, 1 year, 2 years, probably these eyes behave in a different way. See, if diabetes is not under control, later on they develop other issues, that's a totally different. But cataract surgery per se related complication, which you have immediate or that early late post-operative period, like a 1 month, 2 months, up to 6 months you talk about, that part you have taken care of already. So probably I put it as a relative contraindication. Probably somebody wants to put, I won't blame the person. But when obviously you have a macular edema, obviously diabetic retinopathy, if you are doing multifocal, I would say no.
You see, let the message be, broadly speaking, no.
Yeah,
so let's move on. I think I am actually very much impressed by all the panelists and speakers. So much discussion, so much heavy, science going into it. But we have to move on, and we have the last talk, which is the end stage of diabetic retinopathy, where all this proliferation have gone, and now it is TRD. And we have Gopal Pillai from Kerala to tell us about cataracts plus TRD, how he would approach. And to introduce Gopal, we have who is introducing? Dr. Sonu Goyal. Dr. Sonu Goyal will be introducing Dr. Gopal Pillai. Sonu?
Yes, sir. So on behalf of the scientific committee of AIOS, it's my privilege to welcome Dr. Gopal Pillai. He is the professor and head of the Department of Ophthalmology and the chief of Vitreoretina Services, Amrita Institute of Medical Sciences, Kochi. He is an eminent vitreoretinal surgeon in South India, pioneer of 25 gauge sutureless retinal surgery. He is a graduate from the Thrissur Medical College and a postgraduate from the RP Center. He became a diplomat National Board in 2001 and was admitted as a fellow of FICO in 2002 and FRCS in 2003. He did his fellowship from the University of Hamilton in 2009 and the American Academy Certificate course on EMD in 2011. He is a member of the National Diabetic Macular Edema Task Group and a member of the National Optometric Curriculum Development Task Force. He is a reviewer for the American Academy of Ophthalmology and the Journal of Tropical Medicine. 30 international presentations, 300 national presentations, 8 international publications and 4 book chapters. I think that speaks of Dr. Gopal Pillai's scientific contributions. So welcome, Dr. Gopal Pillai, and happy Onam to you.
Thank you very much. Am I audible? That would be the
Yes.
most
Yeah,
common
Gopal.
question everybody is asking, right?
Yeah.
So,
We can see you also.
thank you very much for the kind words. So I'm basically going to speak to you about cataract and TRD. This is a case. Happy all. So this is a 65-year-old man. There was a decrease of vision slowly progressing over the last 1 year in the right eye more than the left eye. And he's having no redness, pain, watering, no other symptoms per se. And he's diabetic on insulin for the last 20 years and hypertensive 15 years on treatment, and recently diagnosed to have kidney disease. So on local examination, his head posture was normal, orthophoric, no facial asymmetry, extraocular movements were normal. The right eye vision was not improving beyond 3/60, and left eye was improving to 6/12, and N18 he was able to read handwriting and larger headings in the newspapers. And both eyes, the anterior segment was the conjunctiva, cornea, anterior chamber, iris, all normal, and the lens showed nuclear sclerosis grade 2 with cataract, PSC, and cortical in both eyes, and there was no cells, and IUP was normal, and gonioscopy was open. This was the right eye, and this was the left eye. There was PSC and almost an amber colored grade 2 nuclear sclerosis. Dilated fundus examination, slit lamp 90D examination showed that in the right eye, the media was hazy. Disc was not seen clearly because of a fibrovascular traction on top of the disc, which is going inferiorly. And there were some hard exudates, plaques, which was seen through that hazy media of cataract, and retina seen hazily. Macula seemed to be attached, which was on ultrasonography, there was a slight lift up of that retina. And because the vision was 3/60 and there was cataract and traction retinal detachment involving the macula, even though it is starting from the disc, this was planned for surgical intervention. In the left eye, media was slightly hazy, but the vision, you should understand, it was 6/12. Disc and margins were well defined and with normal cut disc ratio. Arterial narrowing was present, and fibrovascular proliferation was seen superiorly. Okay. So the diagnosis was both eyes proliferative diabetic retinopathy, straightforward. Right eye was having traction retinal detachment, left eye having fibrovascular proliferation around the disc, both eyes immature senile cataracts, diabetes mellitus, hypertension, and early nephropathy. So the right eye underwent intravitreal injection followed by a combined cataract surgery with vitreous surgery, and the vision improved from 3/60 to about 6/24. And in the left eye, cataract surgery was planned and PRP was done, and the patient was then lost to follow-up and came back after 1.5 years with loss of vision in the left eye too. And that is a point of time when the right eye picture was taken here, post-operative picture. There was a PCO also, which was also accounting for about a one-line drop in vision. And so at the end of 1.5 years, when the patient came like this with traction retinal detachment with a vision of 4/60, he was operated, and now he has about 6/18 vision. So there are some other examples. Now, this is a patient with 6/12. You can see that there is a traction, which is very near the macula, almost touching the macula, which is slightly pulling up on the macula. The cataract is very mild, 6/12 N8. It is planned for pan-retinal photocoagulation. And when you do pan-retinal photocoagulation in such patients with traction, we try to move away from the areas of traction. But then after 1 year, the vision fell down from 6/12 to 3/60 suddenly and operated, and now at 6/24. And after cataract surgery, vision improved to 6/12 parts. Now there's another patient who had not much cataract with 2/60 with TRD, now back to 6/18 with oil and waiting for cataract surgery. If possible, I will do a silicone oil removal and then only plan a cataract surgery. This is again another patient with counting finger close to face, vitrectomy 6/36 with oil, post cataract surgery improved to 6/24. And this is again another patient with hand movements with traction retinal detachment and massive fibrovascularization, now 2/60 with combined surgery. So what I wanted to say is there will be different grades of cataract, right from, very early, immature, if you say there is cataract, yes, there is cataract. If there is no cataract, there is no cataract, to, moderate, grade 2 cataract with, PSC, to white cataract. So the questions that we will discuss would be: one, is cataract a cause of loss of vision? Like if cataract is causing about 2 or 3 lines drop in vision, then definitely it is significant, because proliferative diabetic retinopathy and traction retinal detachments are not like the usual as we understood over the discussions. Prognosis on surgery for cataract. What is the prognosis for surgery for cataract? What is the prognosis for surgery of TRD? And what is the function of the underlying retina, even if we are going to settle the TRD? Should we observe now versus should we operate now? Cataract first or vitrectomy first? Or is it a combined surgery? Intravitreal injection before cataract surgery or before vitrectomy? Combined surgery or sequential surgery? Can silicone oil be removed in this case before cataract surgery? Or silicone oil should be retained in this case? That decides a lot on IOL power calculations also. And so IOL power calculations with silicone oil inside, or in cases in which we are going to remove silicone oil. These will be our discussion points. Thank you very much.
Thank you, Gopal, for raising further controversies. You can unmute. Yeah.
I am not able to unshare. One second, sir. There is some problem here. Yeah.
Lalit, I'll just make No, he made a good improvement, and I think some patients after PRD surgery, if they even improve 360 or 6/60,
thanks.
I think I always say that we should do a LVA. Maybe most of the time they're one eye, and the other has been lost with NVG. So I think many times ophthalmologists forget, or even the patients are not interested. But I think you have to counsel the patient and make sure they use LV, and later they understand they can also read N18 or something like that.
So to discuss these patients, 5-6 questions which last slide Gopal had presented, I'll invite Saurav and Padmaja for making initial comments, then others can pitch in. Maybe Padmaja can start.
I think cataract with traction retinal detachment is a scenario where we should see which is the predominant pathology. So I would always be definitely comfortable, for example, if the cataract media is not hazy enough and I can actually perform traction detachment surgery repair comfortably and adequately, I would go for vitreoretinal surgery first, and then oil, if it is required, oil implantation. And then also is the question about silicone oil removal first or followed by cataract surgery. I think that is also very important to understand that when you remove the silicone oil removal and you will after that sequentially cataract surgery, the studies and as well as the personal experience, those cases actually do better in terms of having an accurate refractive calculation and avoiding too much refractive shifts in these patients. So that's how I consider. Of course, when it is a cataract surgery plus traction retinal detachment is required because of the dense cataract, then again, it all depends on how your backup cataract surgeon is available. Like, for example, I do predominantly vitreoretinal surgery, and I want something, a good view for achieving my traction detachment. So I would actually prefer a cataract surgery first, followed by in 1 week time or something where I could see the view, everything clear, and then I go for the vitreoretinal surgery. Because that is very important, because these are complex surgeries, and the time taken for the duration of surgery also can be prolonged when you combine the surgeries. So it's all depends on how comfortable you are performing both cataract as well as vitreoretinal surgery at the same time.
Shalabh, can you add anything to this?
I will only quote Gopal's first patient, where the right eye had a TRD with vitreous hemorrhage. I would insist on the other eye having PRP first.
Yeah.
Because that patient did well in the right eye, went away. I would insist to all our catechism colleagues, the eye which is already gone, hold on for 2 to 3 weeks. Nothing will happen further into 3 weeks state. Look at the other eye very, very carefully. Do a FA there if you're not confident. Less cataract. Do it if you don't find any NVD. Do an FA. Treat the eye PRP if possible, if necessary. Then come back to this eye first. Otherwise, I agree with whatever Padmaja said.
So this message very well taken, that suppose patient has TRD or advanced disease in one eye, at least save the other eye by good PRP or whatever injections or combination thereof. So any other comment from anybody about this TRD? Because all TRDs may not require surgery. You see, the patient has good vision. The patient has good vision and the only eye with cataract, without cataract. So all TRDs may not require, because for TRD, vision is the main criteria for operating, because we have to ultimately improve the patient, not make it worse. So that is point number one. And yes, Nati, you were saying something?
No, George has some comments because yesterday also we had.
Yeah, I am coming to George. I am not going to leave him, because a lot of comments I have to take from him. He has to leave now.
Sir.
He's there.
Yeah. Yes, Partho.
Yeah, again, from the cataract surgeon's point of view, sir, if the cataract is moderate, good view of the fundus is there and TRD is there.
Yeah.
So in these cases, if only vitrectomy and vitrectomy is done, then even then the cataract is going to deteriorate faster than otherwise.
It's okay.
So why
because
not
the thing is that can wait. Yeah, I agree. Like Padmaja said, if the media permits, I would definitely try to do the vitreous job, without cataract. And does not matter cataracts. After the retina is all set, TRD objective has been achieved, retina is stable, then I would, take the help from cataract surgeon or refer him for cataract surgery. And I, for one, normally, Padmaja, try to combine both cataract, because a lot of biometry advances are now available. Optical biometers are there. Silicon oil mode is there. Most of the times, unless patient is going to record 6x6, in any case, you see these patients are generally, by and large, you see bad TRDs. The 6x6 or 6x5, we are not looking. We are looking somewhere in between. So the accuracy and this thing, although biometers and silicon oil mode also are reasonably good. So I generally combine both SOR plus cataract so as to give the benefit, because operating cataract in a fluid filled eye also poses challenges.
Yeah.
Yes, Santosh.
Sir, I would like to
in case of these advanced PDRs, bilateral advanced PDRs with TRDs, would it make sense combining cataract with vitrectomy, since we can ensure a proper anterior vitrectomy so that there's no further anterior halide proliferation later? Because cataract or any amount of cataract or a phakic lens can limit anterior vitrectomy and then further rebits, rebleeds, and maybe envisage later on in this compromised systemic conditions.
I'll ask Pramod also about this. The thing is, the one stage versus two stage or single stage, you see, depends on how much job you have to do and how much membrane surgery you have to do in the posterior part. If the job is, say, very mild, then combination is very good. If somehow the job, membrane job has to be very extensive, then I would actually do a two-stage cataract surgery first, and then maybe let's have opinion from Dr. George Rosha about this scenario, what Santosh said. You see, combining.
In my place, I do like you are saying. I do first the cataract and plan for 1 week to do the vitrectomy. It's very important to take the cataract, because if you don't take the cataract, you can't clean the vitreous base that can prevent us to have the vitreous base proliferation in hard case. And if you have the cataract, it's hard to photocoagulate well the far periphery. And then I think that the good thing to do is first do cataract, and after that, give a intravitreal injection in 1 week to operate vitrectomy. And most of the time, try to do with gas, C2FA, not oil, because oil is not good for diabetic. But if it's very hard case with many holes, sometimes, or the only eye, I do oil, but sometimes I prefer much more gas.
Giri, any addition to this?
Yeah, I think, everything has been covered well. I think all the points have been covered well. Probably you can just summarize everything together, and that should be,
So one last question from my side.
Yes.
So one last question. Does PRP or an anti-VEGF increases the progression of cataract?
PRP, I'm not very sure. Anti-VEGF multiple may, yes.
The take-home message would be to our candidates, no. Don't get confused by that.
Yeah. Where are you?
No.
I want to ask Dr. George one question. Can I?
Yes.
Sir, in the presence of no cataract, will you remove the lens if you are performing a traction retinal detachment surgery so that you are able to reach the periphery and do good PRP, try till the aura, etc.?
Yeah, it's a very good question. If the patient is young I try to keep the lens. But if the patient has more than 50 years, I used to, even with the clean lens, I try to remove, because this bad case of diabetes, the patient is not well controlled and cataract will come very fast. And then I take the lens. But if the guy is very young, like less than 50, I will try to preserve the lens.
Okay, I think the time has come to summarize everything, and I'll and say thanks to all of you. We had very extensive discussion and very nice presentations. And I'm sorry, Partho, we ran more than what you allotted to us. So hand over to Partho for a summary as well as thanks.
Thank you very much, sir. And as usual, we had the best of chairpersons, the best of an international faculty, the best of presenters, and the best of panel. So it was the best of everything with the best moderator in the world today. So Lalit sir, thank you very much for sparing so much time, effort, and everything. And we have had a phenomenal number of viewers. And I'm sure if there are nearly 3,000 viewers, not all of them are VR surgeons. So the cataract surgeons have immensely gained from it. And I'm so thankful to the whole panel of VR surgeons who have come in, stayed all the way, and contributed so immensely. And of course, my I'm extremely grateful to Dr. George for having spared this time and the whole 3 hours of a Sunday morning. Thank you so much. And it's really wonderful that you could do this. And we invite you to our AIOS annual conference, the AIOS 2021, and that's going to be in Kolkata. So a warm welcome on behalf of the scientific committee, as well as from the two presidents who are here, Dr. Natarajan, as well as Dr. Lalit Verma, and the whole scientific committee team. Thank you very much. Thank you, everybody.
Thank you, Partha, and I think thank you,
George. Everybody. Thank you very much.
Thank you, everybody. And thank the entire scientific committee, being led by Partha Vishwas, but a lot of effort has gone by help of Amit Porwal, Feroz, Bhalla. Phenomenal committee, Partha. You have KP, Parikshit, Somshila, and Sonu Goel. Believe me, they extract everything out of all the webinars. That is the beauty of this.
Your guidance is always there for us, sir.
Yeah. Girdhar sir, if you can come on screen, sir. Girdhar sir, if you can come on screen, we'll take a quick photograph. And great faces and victory signs, sir, from all of us.
Yeah.
So a peace sign.
Great job. Great job.
Thank you. Thank you very much. Thank you. And thank you, viewers, for viewing the webinar. And we'll have many more from the scientific committee. Thanks, everybody. Good night.
Thank you.
Thank you very much. Thank you very much.
Thank you, everyone, sir. Thank you, Dr. Lalit, for conducting it so nicely, sir.
Yes.
Really great.
Thank you, Lalit sir.
As always.
Thank you, Partha
as
sir.
always.
Background, Lalit sir, background बहुत अच्छा है.